Hello, I'm Margaret Kelman, and I'd like to introduce you to the Allergy UK Masterclass webinar series. The Allergy UK provides a support, advice and information for people living with allergic disease, and we're the leading UK-wide patient charity covering all aspects of allergic disease and manifestations, and this includes both IgE and non-IgE mediated allergy. In Allergy UK, we aim to establish ourselves as the voice of people living with allergies. We work in collaboration with a range of stakeholders in order to take forward our vision. So our vision is that no one should die of allergy, and our mission is for everyone to take allergy seriously in the UK with a goal to empower, educate, research and influence. So why do people need us? Well, a staggering 21 million people in the UK, that's 1 in 3 people, have allergies, and more than half of those have more than one allergic disease. And we know that allergies have a huge impact on quality of life and daily activities, including school, work, sleep, and of course, mental health. So Allergy UK, we aim to provide information, advice, and support for the allergic community, to raise awareness of the condition and its impact on quality of life, and to inform, advocate, and behalf of the allergic community. And we do this through the various services that we provide. And this includes our helpline and email website service. So the helpline and web chat is an advisory service staffed by people that are able to listen to people's concerns and help. And this enables people to better understand and manage their allergic conditions. We have an in-house clinical experts to help with more complex questions, and a health advisory board, which comprises about 44 specialists across a broad range of allergy-based specialities, including immunology, dietitians, pharmacists, dermatologists, and primary care professionals. In the last year, we have spoken to about 4,300 calls and answered about 3,000 emails to our helpline. Allergy UK has a very active social media presence and can reach out to many people and families through our Facebook, Twitter, Instagram, and website. And every month, our e-news publication reaches over about 46,000 people, and more than 83,300 people visit our website every month. This includes the Allergy House, Winning Resources, and our online interactive Allergy House has identified hotspots for indoor allergens and attracted 23,879 visitors to date. Allergy alerts. So sometimes foods have to be withdrawn or recalled if there's a risk to consumers that has kind of hidden or incorrect food labellings, or there's any other food allergy risks such as cross-contamination. And we're informed by the Food Standards Agency, and we can alert the public then via our website and by sending emails and Twitters to 17,000 people on our allergy alert list. We have fact sheets, and our fact sheets are produced in-house by our clinical team and then peer-reviewed by specialist clinicians in the field. And we currently have around 70 fact sheets available for downloading free of charge from our website. And in the period of 2019 to 2020, 67,700 fact sheets on a range of topics on our website were downloaded. Allergy UK has also been certified as a quality provider of health and social care by the Information Standards, and we can continue to follow IS guidelines in the creation of our fact sheets. We're also involved in a range of research and surveys, and we're continually being approached by kind of companies and institutes. And surveys and reports is an excellent way for us to explore the lived experience and quality of life and kind of feed back the impact of those affected by allergic disease. And we can reach out to thousands of people on our databases and through kind of the online surveys on our website and through social media. And recent surveys have produced credible research into the lifetime changes faced by those living with allergy. extending our influence so we can connect with lots of stakeholders. And this way we can put forward our vision on a national level with key stakeholders, including NHS and the BSACI and other organisations with an interest in allergy. We also work with key projects with the Food Standards Agency, and also on an international level, we connect across the globe to maintain our aim to be a powerful voice for the allergic community and maintain that our voice is heard. And here are some useful resources to tap into for information. So on to the main event. So today's Allergy UK Masterclass webinar is at One Airway, One Disease, looking at demystifying allergic rhinitis and asthma. So today's focus will focus on allergic rhinitis and asthma. Each session is roughly about 45 minutes long, and questions can be posted using Slido on our webpage or via the app with the hashtag AllergyUK 1606. Slightly incorrect on there, so it's hashtag Allergy 1606. We've got roughly a 15-minute break following session 2, and then session 3 will start at 11:30 and the webinar will finish at 1:05 p.m. You can claim CPD points for attending each live session. You'd need to complete the survey provided in our registration email to claim your points, and then we'll email your CPD certificate roughly kind of 6 to 8 weeks after the event. The webinar will also be available on the healthcare professional section of the Allergy UK website, and we will also email a link to yourselves via your email when you're registered, so that you can kind of watch the event after. You can share this link with colleagues as long as they're registered as healthcare professionals, and they can then contact us for us to claim their CPD points. I'd like to welcome you to our first speaker today. That's Dr. Glenys Scadding. She's an honorary consultant, allergist and rhinologist at the Royal National ENT Hospital and an honorary senior clinical leader at University College London. She's going to be speaking on the topic of one airway, one disease, united and unified. Over to you, Glenys.
Thank you, Margaret, and good morning to all of you. What a lovely morning this is. And I'm very sorry for those of you who have hay fever and are worried about going outside. Just put your hands up and shake it around if you've got hay fever and it's going to trouble you today. I can't see you, of course, but it might make you feel better. My brief is to talk to you today about one airway, one disease, united and unified. Here are my disclosures, and another disclosure that I have allergic rhinitis, which is why I'm keen to teach other people about it. And I'd like to start by looking at a fairly recent study published in 2018 about trying to stop asthma exacerbations in children. And it was over 200 children, and they were already taking inhaled corticosteroids twice a day regularly. And they were randomized into 2 groups. And when they got to the amber zone on their symptom and peak flow score, they were asked either just to carry on with what they were doing or to increase their inhaled corticosteroid 5-fold, a massive increase, to see if that could stop them going into an exacerbation. Here's the answer. No difference between the 2 groups. I think we need a rethink with asthma, because asthma doctors tend to treat the lower airway only. Look at the picture on the left. ENT doctors mainly treat the upper airway. But you and I know that this is all joined up. It's all one airway. And there are massive interactions between the 2. If your nose is working properly, it is your own personal air conditioner. It's filtering, warming and humidifying between 10 and 15,000 litres of air for you every day. If it's not working properly, dirty, polluted air can get down into your lower airway and you're more likely to have problems there. The reverse is also true. Lower airway disease does impinge on the upper airway to some extent. But remember, asthma exacerbations usually start in the nose. So I'm going to talk to you about rhinitis. Now, what it means is nasal inflammation, but it's defined by symptoms: running, blocking, itching and sneezing for more than an hour a day. And in over half the patients, the eyes are also affected with itchy, watery red eyes, and then it's rhinoconjunctivitis. And when it's mediated by the allergy antibody IgE, it is allergic rhinitis or allergic rhinoconjunctivitis. And most asthma patients have some form of upper airway disease, either rhinitis or rhinosinusitis, and they're the ones in green on this diagram. Those in blue without upper airway disease probably don't have corticosteroid responsive eosinophilic asthma. So if you're piling corticosteroids into them, all you will do is give them side effects. You won't be treating their asthma properly. Now, I'd like to teach you using a couple of patient examples. And here's the first one. He's a teenager. He's called Patrick, and he has hay fever. He's got IgE to grass pollen. And whenever he goes out to play football in the summer, particularly in the evenings, he gets wheezy. He borrows his mum's blue salbutamol inhaler and uses that as rescue. And for his hay fever, he just takes an antihistamine when his symptoms are bad. Where is he on those asthma phenotypes? Now, I'm going to use the phenotypes by Haldar et al., and they plot symptoms against the amount of eosinophilic inflammation in the lower airway. Where's Patrick? He's probably somewhere here. Got quite a lot of symptoms, but when you look at his inflammation, it is not high. His pheno is low. So he has allergic rhinitis, and the reason he's got bronchial hyperreactivity is because of the inflammation in his nose. And he needs better nasal treatment. And there's evidence that rhinitis causes bronchial hyperreactivity to allergens and to chemicals like histamine and methacholine. And there's evidence too that putting corticosteroid in the nose is much more effective at reversing this than putting corticosteroid into the lungs. And this is probably because it's largely a nerve reflex from the nose to the lungs, causing bronchoconstriction. But it's not only nerve reflexes that can happen, because Brownstyle showed that if you put a tiny bit of allergen into the nose, wait 24 hours, and then take a biopsy from a small bronchus, the inflammation there increases compared to controls who didn't have the allergen. So nasal allergen causes bronchial inflammation as well. And the same is true in reverse. If you put the allergen in the bronchi, you get inflammation in the nose. So it's like dropping a stone into a pond. You get a ripple effect. The whole airway reacts, which means you need to protect the upper airway. The other thing about allergic rhinitis is that patients with it are over 3 times more likely to develop asthma than patients that don't have it. And this is shown, I want you to look, first of all, the pale greenish line. These are the controls at the bottom. And over 8 years, a small percent, about 1% of those developed asthma. They're young adults. Now look at the red line. These are the ones with allergic rhinitis. Far more of those, 3.5 times more of them, developed asthma. So allergic rhinitis is a warning sign for asthma development. And the good news? Well, If you do allergen-specific immunotherapy for allergic rhinitis, you may be able to prevent asthma development. And this comes from 2 studies, one using the injection form of allergic rhinitis, and the other using the sublingual form. And there are now some real-life studies as well, also suggesting this is relevant. So maybe we should be doing more immunotherapy for those with bad hay fever and wheezy symptoms. Let's move on to patient 2, Shona. Shona's a bit younger, she's 7, and she had the classic allergic march, which is shown by about 10% of allergic people. She had atopic dermatitis as a baby, she got asthma fairly early on, and now she has allergic rhinitis. You can see her problems just by looking at her face. You can see that she has to have her mouth open to breathe because her nose is so blocked up. And you can see the little extra creases under her eyes because her eyes are itchy, and she screws them up and she rubs them. She has got IgE to multiple allergens, and in the winter she's always worse, and every time she gets a cold, her asthma gets bad, and she gets flu ear, which lasts for months. Her life is made very miserable by her allergies. Now, I've chosen these 2 because they exemplify 2 arms of the allergic response. This is quite an old slide of Steve Durham's, but I find it very useful. Patrick is very much at the top part. His symptoms are largely caused by IgE-coated mast cells degranulating and releasing local mediators, giving him wheezing, itching, sneezing, bronchospasm, and a watery discharge, eventually congestion. Shona's symptoms are much more at the bottom, this chronic late phase reaction, with T cells making cytokines that pull in inflammatory cells into the lining of the nose and the lungs. And the eosinophil is that cardinal inflammatory cell. And these patients just block up. Their airways are reduced by the inflammation. Their nose is sticky because of the eosinophils. They often have a poor sense of smell. And the lining, which is inflamed, overreacts to all sorts of things, not only to allergens, but also to changes in temperature, to smoke, to perfume. They are hyper-reactive. And it's many of these patients who get a lot of the comorbidities of rhinitis. They may get rhinosinusitis, they may get otitis media with effusion, and they may get asthma or worsening asthma if they already have it. Where does Shona belong on those asthma phenotypes? Well, she's here. She has so-called concordant disease in that the level of the eosinophils is parallel with the level of symptoms. And Sarah, why am I calling her Shona? Early onset asthma, concordant asthma, and allergic rhinitis. And of course, treatable by pharmacotherapy. But she could still respond to immunotherapy if her asthma is not too severe, if her FEV1 is over 70%. And we know that in both adults and children, rhinitis predicts poor asthma control. And you can see this here from UK general practice data. Significant rhinitis gives you an odds ratio of 4.62 of having uncontrolled asthma. And that's higher than being a current smoker, which is 4.33. It's also higher than the figure at the bottom, which is low adherence with your preventer inhaler. And that's only 1.35. And what that says to me is that a lot of asthma control depends on what's happening in the nose. It's also true in children. This is Mike Thomas' study showing that children who have asthma and allergic rhinitis have more physician visits per year. They are more likely to end up in hospital with their asthma, and they have a bigger economic burden. Their drug costs are higher, they use more short-acting beta agonists, and they have more oral corticosteroids. So allergic rhinitis complicates asthma. And it's not only in the UK. This is a Brazilian study of children and adolescents taking inhaled corticosteroids for their asthma, and 75% of them had allergic rhinitis. And there were 2 factors associated with the use of emergency asthma care. One of them was severe persistent asthma, and that gave you a 2-fold risk of emergency care. The other one, the presence of allergic rhinitis, and that was almost 3-fold. So we need always to treat rhinitis in asthmatics because it also impacts on lung function. It reduces FEV1, it reduces FEF 25 to 75, a measure of small airways. It makes FeNO, a measure of inflammation, higher, and it makes those eosinophils higher. So it's not a good thing to have. And actually, there is interaction not only with rhinitis in asthma, but also with eczema. That increases the problems still more. So those allergy patients with more than one disease are far more likely to get into trouble with their asthma. And do we have good real-life data? Yes. Now that people are beginning to use their mobile phones to monitor their symptoms, and there's an app called Mask Air, which you can pick up for free, and monitor your rhinitis and your asthma symptoms, the results from 41,869 days show a very nice correlation between poorly controlled rhinitis and poorly controlled asthma. And this is the first good data in real life. What triggers asthma? Of course, allergens can in those who are allergic, but most allergens triggering asthma don't get any further than the nose, provided it's working. The exception are thunderstorms. When grass pollen molecules are taken up very high in the atmosphere, fragmented, and then come down and can be inhaled into the chest and cause very significant asthma, even in people who've only ever had hay fever before. And that can be fatal. Rhinoviruses are the other big trigger. And now we realize that pollution too is a huge problem. And these show synergy. That means 2 and 2 adding up, not to make 4, but to make 5 or 6. And there's a very nice example of this in some data from Adnan Kustovic in Manchester, looking at sensitization to allergen. That's S, that means you've got IgE to it, exposure to that same allergen, and then getting a viral cold. And in children who had that triple whammy, they got a cold when they were exposed to an allergen to which they reacted, they were 19 times more likely to end up in hospital with their asthma. Now, there's evidence from good retrospective studies showing that rhinitis treatment reduces asthma exacerbations, hospitalization, or both. So how do we treat it? Well, we make a diagnosis by taking a good history of what symptoms there are, when they happen, where they happen, what makes them better, what makes them worse, taking a look at those, and doing tests for IgE. You may need to do other tests, and there's good guidance at the BSACI, and the website is here, or recently at Euphoria, and the website is there. These are the BSACI guidelines, and we start off advising allergen avoidance and saline douching for everybody to start with. Simple but effective treatment, and often all you need for very mild disease. And then mild disease antihistamines, moderate to severe intranasal corticosteroids. If it doesn't work, check how the patient used it, and you need to teach corticosteroid use, concordance, dose. If they failed on that, we go on to a combination treatment. Now, allergen avoidance, you've got wonderful advice from AllergyUK, from some of those sheets you heard about earlier. But this year, there's something you can do which is very simple and actually works remarkably well. It's what I call the Michael look. You put on your sunglasses to keep the pollen out of your eyes. You put on your mask. It keeps COVID at bay. It keeps pollen at bay. and it keeps pollution at bay. So with those simple measures, you may actually help to reduce your symptoms quite markedly. And then looking at which treatments really work, we can look at the number needed to treat. And nasal sprays, you need to treat 4.4 people to make one person better. That's an intranasal corticosteroid. Look at antihistamines above it. You need to treat 15 people to make one person better. They're not very effective. They are more effective on rhinitis symptoms if you put them in the nose. Look at the third column, azolastine. The number goes down to 5 if you use it twice a day. It's a good drug in the nose. And then other treatments, montelukast, omalizumab, don't have much effectiveness, interestingly. But allergen-specific immunotherapy is effective. 4.6 is the number needed to treat. So think about those two. Intranasal corticosteroids, you need to know what happens when they get into your body in order to reassure patients. And I use one of these 3 on the left here because they are the least systemically bioavailable. There's very little bioavailability from these, so you're not adding to the problem of inhaled corticosteroid. And these are fluticasone furoate, Avamis, mometasone furoate Nasonex, fluticasone propionate Flixenase. Those 3 are the ones to use, especially for children and especially for long-term use. And always, always teach your patients to put the spray next to their toothbrush in the bathroom just before they clean their teeth. Pick it up, give it a good shake, put down as though they're reading a book, use the right hand to the opposite side of the nose and spray the lateral wall on the inside. 1 puff for a child, 2 puffs for an adult, 2 different places, 1 up, 1 back, change hands, same the other side, 1 up, 1 back, wipe, put away, don't sniff, pick up your toothbrush, clean your teeth, forget about your nose. The spray will be on the lining. There are little hairs that will beat it backwards over 10 to 20 minutes. That is when it works. Don't sniff it up. Don't spray it on the septum. You'll get much better results if you get your patients to do that. And they do improve asthma control. This is a prospective study showing improvements in FEV1, bronchial challenge, asthma symptom scores, all improving with nasal sprays. So Patrick was fine. We gave him an intranasal corticosteroid and we started it early, which is a good message for hay fever. A bit late. Start it 2 weeks before, use it every day, and it smooths out the symptoms very well. Shona didn't. She has SCUAD, severe chronic upper airways disease. So she's one of those patients inadequately controlled despite adequate pharmacotherapy. And as I mentioned, she is particularly bothered by this disease. So what do? Well, combination therapy is good here. Azolastine and fluticasone used together in a fixed dose combination spray are more effective than either alone. And this is the combination spray here, this is FP here, this is azolastine here. And the other thing is they work quickly, these combination sprays, because of the antihistamine component, and they are better over the whole 2 weeks of seasonal studies. Not only that, the nasal and the eye symptoms are reduced by a fixed dose combination, and real life studies show they work irrespective of age. So they're good for teenagers and they're good for old ladies like me. There's also studies showing that this combination reduces the need for asthma medication. So because you're putting something in the nose, you can probably reduce the amount that is going into the chest. And here, considerably reduced, about 20%, reduced 50%, so about 70% of them were reducing their asthma medication because their nose was better controlled. If this all fails, we allergists would love to see these patients, and we like to see them for these other things as well. There are other things you can add on yourself, and there's a line here, do go to the guidelines to check. But the last thing I want to mention is allergen-specific immunotherapy. And this is the practice of administering doses of an allergen product a proper allergen product, not something you make up yourself, to an individual with IgE-mediated disease where that allergen is relevant to ameliorate the symptoms, to alter the immune response. The only treatment that alters the course of disease. It can be done by injection. Severe side effects are possible. Specialist administration is mandatory, and it's contraindicated in chronic asthmatics with an FEV1 less than 70%. Or under the tongue. The first dose is given under supervision, and then the patient takes the tablets home or drops and takes them under the tongue. And you can use this in patients with mild asthma, but it needs a very large amount of allergen. Steve Dolan's group has shown us that after 3 years of treatment, and during those 3 years, the symptoms were reduced by 32%, 44%, 37%, treatment ended, but symptoms were still reduced in the 2 further years that the study continued. So this has long-term effect. It works in children between the age of 5 and 11, and it works in teenagers. And I think it is particularly good in those smaller children. They got an almost 40% reduction in this study. And it isn't just grass pollen. You can do it for house dust mite as well. And you can show that with the house dust mite, in asthma control improved on a lower dose of inhaled corticosteroid. And they got a 63% reduction in the subgroup who were taking between 400 and 800 micrograms of budesonide. And that's important because the lung has a huge surface area. It's like a tennis court, and you can absorb steroid very well from it. Absorption from the nose is very small, so it's much safer to put steroid in the nose than the lung. We all worry about adverse reactions with immunotherapy, and they can be severe with injection immunotherapy, although actually in the right hands, this is a perfectly safe procedure done well. With slit under the tongue, much safer. You do have local reactions. Many patients will get itching and maybe even a little swelling and irritation in the mouth and throat, especially with that first dose. That usually wears off after a couple of weeks. Systemic reactions do happen, but they don't cause huge problems. Anaphylaxis has been reported in a very few cases, often when things were not done right. No fatalities. So in comparison, both forms of immunotherapy are proven to work. Both have proven long-term efficacy, although sublingual has not been studied out beyond 2 years. And there's documentation that they probably prevent asthma. But finally, what I would ask of all of you who treat allergic rhinitis patients or allergic rhinitis patients yourselves is that you educate yourself about the nature of disease. You accept the fact that you may need long-term treatment. And I've taken intranasal corticosteroids for over 20 years. You learn how to use it properly, and the directions from the BSACI guidelines are shown below here. You learn about the possible side effects to watch out for it, and you have somebody to contact to talk to about it. And you consider mobile monitoring. Here is my secret weapon talking to a dad and his son. Yvonne Darby was my nurse for many years, and she helped me so much by discussing things with patients. You need to get their trust in order to get concordance. And mobile monitoring is extremely useful in this disease. And there's a new one by Galenus Health in which the doctor can receive the monitoring and give you advice upon it. So my take-home message is treat the whole airway. Thank you for listening.
Thank you very much, Glenys of Cascading. That was just a brilliant presentation. I really enjoyed that. And I'm sure all our viewers will have enjoyed it too.
I hope so.
Are you ready for some questions?
Yes, ask away.
So one of the questions is, how can I differentiate between asthma and allergic rhinitis symptoms?
It's a very good question because, as I said, allergic rhinitis can make you wheezy. So I think the thing to do is, if you've got both, is to make sure your rhinitis is well controlled, that you have minimal symptoms. If that's well controlled, anything remaining is probably down to the lungs.
Can you use Dymista in children? So that's the...
It depends on the license. I think here we have a license from 12 and up, and other places it's 6 and up. It depends a little bit on the license in your country. What you can do is use corticosteroid and intranasal antihistamine separately if you can't get hold of a fixed dose combination, because azolastine is available as an antihistamine nasal spray separately. It's not, I think, as good because it's difficult enough to persuade people to take one treatment. It's very hard to persuade them to take 2 different ones in the nose and then one in the chest. But it's a possible way around it.
Thank you. Remember to keep your questions coming through. It's hashtag AllergyUK 1606. The next question. Sorry.
No worries.
People saying about kind of Dymista and altered taste.
Yes.
The taste of it is kind of off-putting.
It's interesting, this. I can't taste Dymista at all. And lots of the population are like me. And it's genetic. But the people who find it really troublesome are the super tasters. So some of them will simply not be able to tolerate it. Others can find that if they take a drink of orange juice or something after using it, they can get rid of that taste. It's mostly when it's on the back of the throat that you get the taste. So proper use, the way I showed you, onto the lateral wall of the nose will delay that happening, will allow it to work, and then you can wash it down with a drink of orange juice afterwards. The good thing about being a super taster is that you are less likely to get chronic rhinosinusitis, because these taste receptors are actually antibacterial molecules before they became taste receptors. They're part of your innate immune system.
Thank you. That's quite interesting.
Yeah, isn't it?
Yeah. So another question. Are you advising nasal sprays are the way to go for hay fever rather than oral tablets, or are you recommending continued combination?
There's very little evidence that adding an antihistamine to an intranasal corticosteroid makes any difference. In the nose, things that go locally in the nose work much better. And I think that's why the intranasal antihistamine has a number needed to treat of 5, whereas the oral has a number needed to treat of 15. I think oral antihistamines are fine for very mild disease, but they must be non-sedating. Never use a sedating antihistamine for anything these days. They have too many adverse effects. But they are not very effective, and they make very little difference to the regular use of an intranasal corticosteroid, whereas adding an intranasal antihistamine does improve it.
Thank you. So another interesting question. Can babies under 1 get hay fever?
Rarely. Hay fever doesn't usually start until you've been exposed to pollen for a couple of years. So it's often children 2 and up, 2, 3, and it gets, the graph goes up after that quite a lot, quite fast. If your child under 1 has some form of nasal problem, start off using a little saline spray if that can help them to feed, because sometimes kids with blocked noses have difficulties in feeding, especially from a bottle. And if there are still problems, see your GP.
Thank you. If an adult patient has a positive skin prick test or IgE of 100 for house dust mite, but asthma symptoms are managed with LABA and inhaled corticosteroids, is there any benefit using immunotherapy?
That's a very good question too. There's a trial by Christian Verkhoff looking at the effect of house dust mite immunotherapy in asthma. And this was sublingual. And he showed that what they did was they started off the immunotherapy, and then I think it was after about 6 months, they halved the dose of inhaled corticosteroid, and then a few months later, they stopped it altogether. And they monitored the time to exacerbation. And he showed very clearly then that the house dust mite immunotherapy reduced asthma exacerbations compared to placebo. So it adds a different kind of quality of treatment. And I think if you want to get to the root of things, using it might be an advantage, especially if you are having exacerbations on your current therapy. I think we should be using immunotherapy for the difficult disease at the moment because it is time consuming, it's expensive. And if you've got well-controlled asthma, I would probably not do the immunotherapy. I would do house dust mite precautions according to your leaflets.
Thank you. There's another interesting one here. How much should you be concerned about the cumulative effects of inhaled corticosteroids and nail corticosteroids when prescribed for children with both asthma and allergic rhinitis? And then probably as well as eczema as well with topical
That's
steroids.
absolutely a good question. I think the answer to that is we should be concerned. And one thing to do is to monitor growth. In children, growth is a very, very sensitive monitor for having too much corticosteroid. And if growth stalls, then you're having too much corticosteroid. The skin, of course, is a very good vehicle for corticosteroid absorption. And the first thing to do with the eczema would be to try tacrolimus or some other treatment other than corticosteroid. The lung is a moderate vehicle for corticosteroid absorption. There's very little from the nose. With those three molecules I showed you, the nasal surface area is tiny. What absorption that does happen comes from the gut, because what goes in your nose goes down the back of the throat and gets swallowed. But it is tiny compared to what's happening in the lungs and the skin.
Thank you. Do you feel there's a role for sinus douching?
Yes, I'm very keen on using saline in the nose, both for rhinitis and for rhinosinusitis. It's a very good way of getting allergen and allergic mediators out of the nose and washing away quite a lot of pollutants. For rhinitis, I think a saline spray is sufficient. For rhinosinusitis, you need one of those big volume douches, about 250 mLs. And there's evidence that to do that in children, you need less nasal corticosteroids, so it's steroid sparing as well.
So there's another question here. It's kind of, what's the role of antibiotics in allergic rhinitis?
None.
And if you're going to use them, how long? None.
No antibiotics. It's not an infection. Why on earth would you use antibiotics? None whatsoever.
There's another one here for this corticosteroid and antihistamine nasal spray. Are we supposed to use the nasal spray for 1 month and then move to steroid only, or do we use it long term?
That's another great question. I mean, my advice would be to use it until you've got control, until the disease is well controlled, and then, provided you're not in the middle of the hay fever season, I wouldn't step down in the middle of a hay fever season. Try stepping down and see whether a corticosteroid alone will do it. I use a corticosteroid alone most of the time, but I use a combination at times when my symptoms are worse. And I think very similar to asthma, really.
What products would you recommend in the younger age groups that are kind of under fives? If if saline, oral, or inhaled corticosteroids are having minimal effect?
If saline or oral corticosteroids, I wouldn't advise oral corticosteroids. I think in the under fives, saline and a non-sedating antihistamine is probably a good starter. If they can tolerate the azolastine, I think azolastine has a license down to 6 in the UK. It varies very much. But I have used, Vitsa Fockens and I did a study years ago using an intranasal corticosteroid in children aged 2 to 4. And we did show that it was superior to an antihistamine. So I use off-license corticosteroids in small children, and I tend to use one called mometasone furoate because the container is quite neat and it's quite easy to get the spray in. With any child, if they can spray it themselves, it's much better than you doing it for them. And with smaller children, if they're very resistant to the idea, what you can do is when they are fast asleep at night, when you go to bed, you can just pop the spray in their nose before you go to sleep. Because it doesn't need sniffing, it doesn't need breath holding, it just needs to go on the lateral wall of the nose. And that is my advice. Now, that's off guidelines, off license, but that is what often works. And if that's not working, the next thing I would think about would be to see whether a leukotriene receptor could add anything into the mix. And I would try that for a month.
Brilliant. Thank you. I've got a request here. Can you describe how to do saline douching for children and for adults, please?
Yeah.
And
what I would recommend is that you buy a bottle for saline douching. I mean, the ones that several different ones now, and you make it up. They will usually provide you with a little sachet. So you start off using that, you make it up, you put the powder into the bottle, you add previously boiled water allowed to become tepid, you mix it up with the top on, and then you go quietly into the bathroom on your own and lean over the sink, turn your head sideways and do a good squirt in one side, then the other side, and you keep doing that until the bottle empties, and then you let the whole lot pour. What you will find is that not all of it comes out, and later on in the day, when you're bending down to get something out of the oven, your nose suddenly runs. But that's just shows you that the sinuses are bigger than you think.
Is kind of that form of saline douching suitable for children, or would you prefer use
Yes.
saline drops?
I think it depends what they've got. If they've got rhinosinusitis, then douching is probably more effective than drops. If they've just got a little bit of rhinitis, then drops or a spray are fine. They will help to wash the nasal lining. But if you want to get to the sinuses, you need a bigger volume. Everybody finds douching horrible to start with. It's not pleasant. But once you get used to it, especially if you've got rhinosinusitis, the improvement afterwards is so good that most people will carry on doing it.
Thank you. There's another question here. What antihistamines can be given in pregnancy? Are we talking sedating or non-sedating antihistamines?
Okay, never use sedating antihistamines at all. That's number one. And secondly, you look for one which is category B in pregnancy. But if it's for rhinitis, I would prefer to use an intranasal corticosteroid in pregnancy. And that's what I do. If you think about it, women with asthma have taken inhaled corticosteroids during pregnancy for years without problems. There are surveys looking at this, retrospective surveys. So adding an intranasal corticosteroid that's non-absorbed, I think, would not be a problem to this. I think budesonide has a category B for pregnancy, although its absorption is a little higher. But I would use an intranasal corticosteroid rather than antihistamine.
Thank you. There's another question. Are you still okay for questions?
Yeah, sure. Are you okay for time?
We're okay, thank you.
Yeah.
Can patients so if a patient doesn't have a raised IgE, can they still technically have hay fever?
Yes. Yeah. What's very interesting is that in recent years, we've realized that you can have what's called local allergy, with all the IgE being present in the nasal lining. And that means that you have the symptoms, but you don't have IgE on skin prick testing, and you don't have IgE on blood testing, but you do react if somebody puffs grass pollen up your nose. And that is sometimes the case in children. And I think in them, it's sometimes a stage in disease development, because sensitization probably takes place in the lining of the nose. The best thing to do in that situation would be to give hay fever treatment. And I would give probably an intranasal corticosteroid and see if it helps. That's
very interesting. Thank you.
You're welcome.
Another one here, do leukotriene receptor antagonists, normally licensed for asthma, help with allergic rhinitis?
Yes, they can do. There are trials looking at them in allergic rhinitis. They are about as effective as antihistamines. I think the number needed to treat is about 14.2. So they're not massively effective, but they do help somewhat. And the interesting thing about these drugs is that some patients respond to them very much better than others, which is why what I tend to do is give them for a month, because they take time to build up to their main effect. And then if they're not working at all, just stop them. If they are working, keep them going. But in children, you do need to watch out for the occasional child that can get psychiatric type side effects from them, and then they need to be stopped. But they're very good for the child or adult with allergic rhinitis plus asthma, because they do actually, when they work, help both diseases. And occasionally they can really alter a patient's quality of life. So they're certainly worth a try, but they're not first-line treatment.
And I've got another question here. Should we do allergy testing for allergic rhinitis, or just go based on the history of the allergic reactions?
I think that depends where you are and the patient's history. Let's say, for example, that Patrick comes into your surgery and he tells you that every summer he has these same symptoms and they come at the time when the grass pollen's out. I think that's a fair history, and his eyes are affected. His eyes are itchy too. That often means allergy. I think with that history, I would be prepared just to treat him. With Shona, I think she's a more complex patient, and I would like to do IgE tests on Shona because I want to know what she's allergic to so I know what I can advise her mum to help her avoid. And also because if her asthma is not too bad, if it's well controlled, we might be able to give her immunotherapy at this stage and possibly alter the long-term course of her disease and improve her quality of life. So it depends a little bit.
Thank you. Well, there's a lot of kind of very positive comments there. All thanking you very much for your talk and saying thank you very much for practical help. I think it's going to be a great help with all their kind of consultations. So that's fantastic. Thank you very much, Glenys.
Don't forget the Michael Jackson look. Bye.
Thank you.
Goodbye.
Bye. Thank you very much to Glenys there for an absolutely fantastic talk. We're now going to move on to our next speaker, Dr. Tariq El Shanawy, who's a consultant immunologist from Cardiff, that's NHS Wales, who's going to talk on diagnostic testing, who, when and why. Remember at the end to send in your questions via Slido with the hashtag AllergyUK 1606. Are you ready to join us, Dr. El Shanawy?
Yeah, thank you for the introduction and yes, asking me to speak today. And so I'm going to be talking about diagnostic testing, and that was an excellent talk and some good questions there. So hopefully they'll be answered at the end of this talk. So so in terms of allergy testing, there's a range of tests out there. There's and I'm going to go through these: the skin prick testing, specific IgE testing, food challenge, tryptase, eosinophil counts, and patch testing. But the most important one, in many ways, is actually the clinical history. That's still the most important tool in the vast majority of allergy. So allergy testing, it adds useful information. There's no test which is perfect, and there's no test which you can rely on to give you the answer. It's all parts of the jigsaw, and it's most useful when there's clinical suspicion of an allergy, but maybe the allergy isn't completely clear cut. So to use the example from the previous one, someone with clear cut summer allergic rhinitis and conjunctivitis. Unless you're thinking of desensitization immunotherapy, which is a 3-year course of treatment, the test there isn't necessarily going to change your clinical approach. But there's plenty of other circumstances where allergy testing is actually really useful. So one example would be a patient who halfway through a pad Thai meal develops symptoms of allergy with symptoms completely consistent with anaphylaxis. He goes to A&E, requires adrenaline, and then on discharge, as per Resource Council guidelines, anyone who's had an episode of anaphylaxis should be referred to an allergy clinic, and this patient is. And the differential diagnosis here is really between peanut allergy and shellfish allergy. So it's about 50-50 between the two. And this is an example where performing allergy testing would be really useful and really informative. So when testing might not be so helpful, so that this is a patient who suffers with recurrent hives. They've been present for weeks or months. The hives are there every single day without any symptoms, and there's no consistent triggers. This patient is suffering a spontaneous urticaria, which is not an allergy, and doing allergy testing may throw up a false positive and cause needless avoidance of food. Sometimes patients are told to start avoiding a particular food, sometimes peanuts, yes, this is a case where it's not an allergy, and treating the urticaria is more important than avoiding foods unnecessarily. So starting off with skin prick testing. So this is a test which involves placing a drop of allergen extract, or the other way of doing it is, rather than using the commercially available allergen extracts, something called prick-to-prick testing, where you place the small lancet into the food and then directly onto the skin. So those are the two forms of skin prick testing which can be done. And the allergen is just introduced into the epidermis. If you draw blood, you've been too harsh. So it should be a pretty minor procedure, and it's often done on children to avoid needing blood tests and so forth. Also with a test, you should have a positive control, which is the histamine, and a negative control, which is the plain solution. And generally accepted, greater than 3 millimeters is felt to be positive. And you read the results about 15 minutes later. And the advantage of the test is that it's rapid. You get the result in about 15 minutes there and then in clinic. The patient can also see and feel the results. So if you're trying to convince someone that they actually really do need to avoid peanuts, then that can be helpful. The disadvantage is that in terms, certainly of the commercially available extracts, there's a relatively small repertoire compared to blood tests available. Antihistamines interfere with the results. So if someone was on antihistamines, you would see the positive control not come up, which would indicate that you can't rely on the test. But patients need to stop antihistamines about 5 days before attending clinic, which, if they're reliant on antihistamines to control their symptoms, obviously is not great for the patient. And the other thing to say with skin prick testing is that there's actually significant both inter and intra-operator variation. So even the same person doing the test on a different day, you see different measurements. It'd be unusual for a positive to turn into a negative and vice versa, but the size of the wheel can vary significantly, which is probably partly operator dependent, but also quite possibly partly patient dependent in terms of what else is going on that day. So then in terms of specific IgE testing, this is a blood test, and significant range of tests available, 800 and growing. There's a cutoff of 0.35 between negative and positive, but of course a level of 0.3 and 0.4 is not really significantly different. The units are arbitrary, so you can't add up all the specific IgEs and expect to equal the total IgE. So the units between specific IgEs and total IgE are different. So they wide range for food, animals, spores, pollens, insects, mites, venoms, smaller repertoire for drugs, and actually drug testing I'll get onto in a moment. Yeah, so then in terms of just to answer one of the questions which has come through. So generally what's said is, yeah, so what's a positive for a skin prick test? It's greater than 3 millimeters is usually said to be positive. And you need a positive histamine wheel to be able to rely on the results. So it's not 3 millimeters bigger than the positive control. It's just bigger. It's greater than 3 millimeters. The negative control should, of course, be negative. Now, sometimes you will see a wheel on the negative control, particularly if patients have dermatographism, and that makes the skin prick tests a lot more difficult to interpret. Sometimes you can see a pattern. So, you know, the negative control might be a small wheel, the histamine will be a big wheel, there'll be lots of small wheels, and then one of the allergens will stand out as being much larger than the rest. But in general, it gets a lot more difficult to interpret if the negative control is positive for obvious reasons. And you should really be taking things with a much bigger kind of pinch of salt. So this slide is now around interpretation of skin prick testing, and what does the wheel size mean? And on the top half of this slide, you've got 50 patients who do not have peanut allergy, and you have the size of the wheel to peanut on skin prick testing. And as you can see, most of them have zero, no wheel whatsoever. But around a third of them do have a wheel, which on the most part is quite small, 2 or 3 millimeters. There are a few which go above that cutoff and have a 4 millimeter, or in one case 7 millimeter wheel. At the bottom half, again, 50 patients with skin prick testing results, this time with confirmed peanut allergy. And so what you can see from this is that there is one patient with peanut allergy who actually tested 0. So a result of 0 is very good at ruling out allergy, but not perfect. And then you can see for the higher wheels, 8 millimeters and above, that in that group, everyone has peanut allergy. So the larger wheels are very good at ruling in peanut allergy. And then you've got this middling grey area of kind of 4, 5 millimeters, where actually you may as well toss a coin, pretty much. It doesn't really tell you one way or the other. So, and of course, it's very hard to give an absolute cutoff, but negative results are good at ruling out allergy. Very positive results are good at ruling in allergy. And then there's a grey area in the middle, which just doesn't tell you one way or the other. And then you see exactly the same kind of thing with specific IgE testing. So although the cutoff of 0.35 is used to differentiate between positive and negative, if you use a cutoff of less than 0.1, that is much better at ruling out allergy, but at the cost of potentially missing some allergy. And then with the specific IgEs, levels of kind of 5, 10 upwards are very good at ruling it in. but there is still quite a grey area in the middle. So that's so again, clinical correlation is required, and it can also be a pattern. So if you're testing a number of things and one is significantly higher than the other, then that's obviously where the suspicion is going to lie. So in terms of specific IgE ranges, there's a grading scheme which really just emphasizes that this is a logarithmic range. It's not linear. So you see results all the way from decimal points up to greater than 100, and it gets, of course, quite hard to give a definitive cutoff, but kind of when you're getting to grade 3 and grade 4 above, it becomes very likely allergy is there, with a few exceptions, as I'm afraid there always are. But and less than 0.1 and grade 0 is good at ruling it out. So then this gets on to the other thing with specific IgEs, is that all the specific IgEs are given the same reference range, whereas and certainly we don't do this with autoimmunity, and with allergy, different specific IgEs perform differently. So this is a study which is asking a slightly different question for what we normally ask in clinic. And this is from America, where they do a lot more food challenge testing than in the UK. And the question asked was, at what cutoff can we say they will 100% react to a food challenge and do not need to have it done? And as you can see, that the cutoff actually varies between the foods for where you're at the point of being 100% certain allergy is present. Now, the problem with using that as a cutoff is that you then miss some cases. So and using those levels of cutoff, you actually miss quite a lot of cases of allergy. But the main thing is that they do vary between the different tests, and some tests such as soya and wheat, you see quite a lot more false positives than you do in some of the other allergy tests. And then specific IgEs to drugs I mentioned, and they're available to a more limited range, but interpretation is different from the other specific IgEs. Drug reactions can have a number of different mechanisms. They can be IgE mediated, but there are also a lot of non-IgE mechanisms involved in drug allergy, and some delayed onset things, and Stevens-Johnson's will not be picked up, for example, with specific IgE testing. So a negative result to drug does not mean the drug is safe to give. And the other thing which can happen, so penicillin is an example. Penicillin can bind to proteins in the blood stream, and then you're allergic to that combination of penicillin and the self protein, which is called a neoantigen. So testing to penicillin will be negative in that scenario, but you will still have an allergic reaction. And in fact, NICE state that specific IgE should only be available to clinics specializing in drug allergy for that reason. So this is separate from, it should be thought of as separately from the other specific IgEs. So then moving on to total IgE. So total IgE, as it says, simply measures how much IgE you have. It doesn't measure what it's against. And what it's against is the important thing in having an allergic reaction. So there's reference ranges. 95% of people will have a level of less than 81, which is one of the frequently used cutoffs. But actually 1 in 20 people will have a raised IgE. 1 in 20 healthy non-atopic people will have a raised IgE. and some may have up to several hundred. And so, as was asked with the last talk, normal IgE does not rule out allergy. You can have normal IgE, but if you're making it against grass pollens, you can have hay fever. So normal amounts, it doesn't matter. It's what it's against, and it's the specific IgEs which are important. Causes of a raised total IgE may just be normal for that person. As I said, 1 in 20 people is normal in. Current or previous eczema, current or previous asthma, current or previous allergy. So someone who's had asthma or hay fever or eczema who's outgrown it may well still have a raised total IgE, even though they have no allergy at the current time. Worldwide, parasitic infection is one of the most common causes of a raised total IgE, but obviously of less relevance in the UK. In eczema, you can see IgEs of many thousands, sometimes 10,000 plus, and they have eczema. It doesn't automatically mean that they have an allergy. Where the total IgE is helpful is it's helpful in interpreting the specific IgEs. So if you have someone with a raised, so whenever I do specific IgEs, I'll always do a total IgE as well. And the reason for that is that if you've got a very raised total IgE of a number of hundreds or a number of thousands, that increases the chance that you may get a low level positive. It increases the chance of kind of having, it's not really a false positive because the specific IgE is there. It's just that it's not causing allergy. So, and it's this link between the specific IgEs and the presence of allergy. In general, the link is good, but there are scenarios such as local production in the nose in someone who has hay fever and you can't detect it in the serum. It's not the usual, but it can happen. That's, and yeah, so just get the next slide up. So then moving on to food challenge. So this is a test where essentially under carefully controlled circumstances, you expose the patient to the suspected allergen. Starting off with a small dose and increasing. And it's obviously done in hospital as a day case in case of reaction. The gold standard is a double-blind placebo challenge. And it's a good test, although it's quite intensive in terms of clinic space and staff time. And it is helpful, but does still have some limitations. So that there are two limitations. One is that it can be difficult to, in some cases, differentiate between a panic attack or a food phobia or anxiety and an allergic reaction. But the good thing is that the patient is there and we can observe and aim to kind of differentiate that as much as possible. And that's sometimes where the double-blind placebo can come into play. And the other limitation is something called cofactors. So most food allergies, if you eat the food, you will have a reaction. But there are some cofactor-induced food allergies. So exercise is one of the most common ones. And in this setting of exercise-induced food allergy, often wheat, but it can be other foods. If the patient eats wheat, they're fine. If the patient exercises, they're fine. But if within a number of hours of eating wheat, they exercise, they'll have an attack. And co-infection with a viral infection, sleep deprivation, alcohol, NSAIDs, aspirin, those are all things which can cause cofactor-induced allergies, and a food challenge will not always pick those up. So moving away from trying to identify the allergen now, I'm going to talk about tryptase testing, which is really aimed at looking at has anaphylaxis occurred. So ideally, these are performed as close to the onset of symptoms as possible, and then at about 90 minutes afterwards, with another sample taken at greater than 24 hours. And in anaphylaxis, what you will often, though not always, see is a rise in level at around 90 minutes and then dropping back down to baseline. It's really, obviously, these can only be done at the time of anaphylaxis. So it's a missed out opportunity if they're not performed. The baseline sample can be taken at any time greater than 24 hours. So it's not a reason not to send them, and it's not a reason for the lab not to process them, just because because the patient isn't staying in overnight or isn't staying in for more than 24 hours before discharge, because that can always be done, weeks or months later when they attend the allergy clinic, or at any time that can be taken. In terms of interpreting the tryptase, positive with a normal baseline is strongly supportive of anaphylaxis. There are different ways of looking at it. A normal result, which is more than doubled from baseline, picks up more anaphylaxis, so it's more sensitive, but at the risk of labeling some people with anaphylaxis who haven't had it. So it's less specific. And then the other thing, a positive peak is very useful, but negative does not completely rule out anaphylaxis. So it may just be that they've had an allergic reaction which hasn't been significant enough to cause tryptase release. The timing might have been out in terms of when the blood samples were taken. And you do see some differences whereby venom allergy is more likely to cause tryptase release a rise in serum tryptase than some other allergens. So it's useful, but again, it needs to be interpreted in terms of the whole picture, including the other tests and the clinical presentation. So then another test, obviously as part of a full blood count, is looking at eosinophil levels. And in terms of eosinophil levels, these again can show that something is going on, but don't necessarily tell you what. And for a slight raise in eosinophils, again, with nearly all lab tests, they're defined as where 95% of healthy people fall. So 5%, 1 in 20 people, will fall outside the reference range. When they do so, it's usually only by a small amount. So if it's significantly raised, it's relevant. And so you see raised eosinophil levels in allergy, in eosinophilic asthma, but not other forms of asthma. Some drug reactions, and again, worldwide parasitic disease. As the levels go up, you start getting into potentially some more severe conditions, such as ABPA. And when the levels are really raised, greater than 5, though it's rare, you need to start considering things like hypereosinophilic syndrome, especially if it persists. So yeah, but I think that the list from eosinophilia is pretty long, and again, it's going to be narrowed down by the clinical history and examination and so forth. So then skin patch testing. So this isn't something I do myself. So it just comes with that provisor. It's to investigate contact dermatitis and is performed in dermatology. So in terms of referral, if the suspicion is over contact reactions and contact dermatitis, I can't speak for everywhere in the UK, but certainly in many places in the UK, dermatology would be the correct referral route, because then in this scenario, you're thinking of patch testing. Patch testing involves placing the items of suspect, and that there's a variety of different panels which are often performed on the patient's back, and they're left there for 48 hours and often read at 24 and 48 hours. And these pick up things such as metal reactions, like nickel is a common one, PPD is a black hair dye, and MI, balsam of Peru, lanolin. Those are some common ones, but the list is long and of potential ones. And usually, what's the kind of verdict given at the end is around this is a kind of ingredient item which is of relevance or maybe is not of relevance. It's been found on patch testing, but actually there's no exposure at the moment, so it doesn't actually explain the rash. So now I'm going to kind of change tack and go back to specific IgE testing, but now go into it from a different angle with something called component resolved diagnostics. So what I've talked about so far has been specific IgE testing to extracts. So an extract from the allergen source of interest, which will contain many different proteins. So so for example, with house dust mite consists of about 5,000 different proteins. And ideally, you want, in the extract, you'd want as many of those as possible in it, so you're getting the broadest range, but also you want to make sure that those few proteins, which tend to cause the allergy, are in the extract. And the naming for component testing is essentially comes from the species name followed by a number. So peanut extract is obviously peanut extract, and then the peanut components be called ARA H1, ARA H2, ARA H3, and so forth. And there's a international naming scheme for the different proteins involved in allergies. So component resolved diagnostic tests for which protein causes it, there is specific IgE detectable to. So one example of where this has proved useful is actually by combining an extract and then adding in some extra protein. So latex, if we go back many years, had really quite poor sensitivity and would miss a lot of cases of latex allergy. And the reason for this is that one of the proteins which causes a significant proportion of latex allergy is actually quite fragile and isn't present in significant amounts in the extract. So now the test is effectively spiked with recombinant HEV-B5, that particular protein, and the assay now performs much better. So that's one use of recombinants. The other role is trying to differentiate and particularly trying to risk stratify. So to talk about where this can be useful, there's a condition, oral allergy syndrome, also sometimes called pollen food syndrome, which affects people with hay fever. And there's a cross-reaction between proteins present in pollens and those present in a number of plant foods. Usually it's fruits, but it can also involve vegetables and or nuts. In oral allergy syndrome, it's or one form of it, there's a particular protein called PR10, which causes this cross-reaction. And this is destroyed by heat, by processing, and probably also destroyed by gastric acid. So what you see is that patients tolerate the food if it's been cooked or processed, but don't tolerate the raw forms. So they get an itchy mouth after apples, but they can eat apple crumble. It can be a difficult one where children can't eat hazelnuts or can't eat fruit, but they can eat all the puddings and Nutella and so forth, and they're not always believed by their parents, but it is a well-recognized condition. Now, oral allergy syndrome, due to PR10, will result in mild local itching of the mouth. For example, if you ate monkey nuts, for example, which is very different to nut allergy, which will cause anaphylaxis. I think the only time where you can see severe reactions with oral allergy syndrome is with smoothies, and that's because it's blended, it coats the mouth, coats the esophagus. It's yes, a big exposure rapidly. It's still a local reaction, but obviously significant swelling is to be avoided. So, and this is what the component resolve testing can tell you. So if you've got symptoms after hay fever and symptoms after multiple plant foods, and you test positive for PR10 and test negative for LTP, we're pretty much reassured that the reactions are going to be mild. And the advice for PR10 is avoid the foods in the forms which cause symptoms, but it's very unlikely that a trace amount will cause severe symptoms, and in general, those patients aren't prescribed EpiPens. However, if you test positive to something else called LTP, then that's a different scenario. It's heat stable, and it's a risk factor for more severe reactions and potentially anaphylaxis. You see much more LTP syndrome in Southern Europe, where in areas where there's olive tree pollen. Less so in the UK, but it is seen. Just because it's less common doesn't mean it doesn't happen. It can be a difficult condition to give advice with, because there's significant variation between individuals in terms of which plant foods are involved. So you can't give a patient a list of these are the foods to avoid, because it varies from patient to patient, and there's also variation between patients in terms of the severity of reactions. So some more components. It can also be useful in investigating peanut allergy. So currently we have available ARA H1, 2, 3, 6, 8, and 9. ARA H2 carries a very high risk of severe reactions. And actually, an ARA H2 of 0.35 is avoid all peanuts, avoid all traces, carry adrenaline and auto-injectors. Yeah, I think I mentioned EpiPens earlier. There are other adrenaline auto-injectors out there. I should use the generic term. So, and then you get some other ones of risk of cross-reactivity with soya, but they're not perfect. So, patients with RH3 can tolerate soya. Others will react to soya even without a positive RH3. So, all of these things essentially help risk stratify. Don't always give an absolute answer. ARA H8 is the PR10 protein in peanut, and that, if that's positive with everything else being negative, they're likely to have oral allergy syndrome. However, if ARA H8 is positive and ARA H2 is positive, obviously they're at high risk of severe reactions. And ARA H9 is the LTP in peanut. So then we move on to microarrays, which I'm going to mention because these are, and again, there's also another type of microarray called ALEX, as well as the Isaac one. Both of these essentially measure multiple specific IgEs at a time, and you can look for patterns that, is there PR10 positivity across multiple pollens and foods. NICE have looked into microarrays and as technology appraisal, and essentially said we don't know yet. More information is needed, but some allergy clinics will use these for specific patients. So in summary, I've gone through skin patch testing is for contact dermatitis and is very different from skin prick testing and specific IgE testing. Tryptase, please measure if someone's having anaphylaxis, ideally at 0 and 90 minutes, but as close to as you can get. And that is helpful then in the allergy clinic to aid interpretation. Total IgE doesn't tell you a lot by itself, but it's helpful in interpreting specific IgEs. And I think that interpretation works both ways. If it's very high, you can get more false positives. But actually, if the specific IgE is normal or low, then you would put more weight on a weakly positive specific IgE than you might do in the other scenario. Specific IgE is useful when low or high, intermediate levels, possible grey area, but they can still be helpful. So if everything is less than 0.1 and there's one test which is 0.6 and it fits with the clinical history, so if you go back to that pad Thai example, you know, that's still helpful, but they're just harder to interpret at that level. And then finally, component resolve testing can help risk stratify, and it can also help differentiate between primary allergy and cross-reactivity. So thank you very much.
Thank you very much, Dr. Tariq El-Shanawani. Are you ready for some questions?
Yes, I am.
Brilliant. Yes. That was an absolutely fantastic talk. It's really, really interesting kind of description of all the kind of allergy tests that are available. And as you can imagine, there are a lot of questions that you've generated during your talk. So we'll go to the first. Yep, go to the first question. This is kind of to do with private tests, actually. So how do you manage patients who've had private IgG or other tests, intolerance tests, and present with numerous lists of different foods they're allergic to? So what would your kind of advice be for kind of clinicians to manage these patients?
So, there's a few things there, but and allergy suffers with the dual problems of underdiagnosis and overdiagnosis. And clearly avoiding multiple foods is restrictive of your diet, is not healthy, and especially in children, you know, it affects growth and so forth. So you obviously don't want to miss an allergy, but you also don't want to needlessly avoid food. So correlation with the history is important. Specific IgEs, as I've discussed, you know, that the tests done in the NHS and the UKAS accredited, which is the accreditation scheme for laboratories, still have their limitations. And I'm going to talk about, you know, tests in general, but there are tests which have less performance than specific IgE. What I'd suggest is there's a so I think if someone's eating something and not getting symptoms, whatever the test says, they've done the real life test and continue eating it. And this is one of the risks of kind of doing screens, and one of the risks of kind of direct to consumer testing is that multiple foods might be tested even when there's no symptoms. There's a booklet, patient information produced, which was in conjunction with a number of organisations, including AllergyUK, from it's Sense About Science. And if you Google making sense of allergies, it will be the top hit. And that kind of goes through some of the private testing which is out there.
Thank you very much. That's quite interesting and useful. So there's the next lot of questions are all to do with kind of skin prick testing and talking about kind of interpretation of the skin prick test. They're saying, talking about kind of skin prick testing, What is the kind of size of wheel you would expect for a positive test?
So the cutoff is greater than 3, but you also get false positives. So a 10 millimeter wheel is much more convincing of allergy than a 4 millimeter wheel, which would be, it might be there, it might not be there.
Thank you. And keeping on that subject, if a wheel is asymmetric, how do you measure it? Do you take the largest diameter or the average of the two measurements?
So there's there's a variation out there. Some people take the largest diameter. Some people will measure both. Others will actually put sellotape over the skin prick testing and draw around it. So then you've actually got a record of it in the notes. There's not a necessarily a standardized way for doing that.
Okay, thank you. And then we've got for the prick to prick. There's 2 questions here. One is saying sometimes prick to prick produce a different result when you use the fresh fruit or vegetable to the allergen solution of the same food. Why is this? And is it more reliable to do prick to prick than use the allergen solution?
So prick to prick can give different results because processing can change the allergens. So you may well, in oral allergy syndrome, you might be getting more likely to get a positive prick to prick than from the solution. Which one's best? It's more that both have different pros and cons. So the allergen solutions are very well standardized, and also known not to have an irritant effect at the concentration in the vials. Whereas with prick to prick, what you don't know is what's the rate of non-allergic people who test positive on a prick to prick, but it does have the kind of pure allergen, not processed, and ideally you try and get some from the skin, some from the inside of the fruit, some of the, and you've got the opportunity to kind of make sure you're getting protein from all the different parts.
Thank you. Are there any foods that you cannot do prick to prick testing with?
Trying to think of any. I think you could probably do it with most. The problem is that it's not going to be as validated as it is with the solutions. I'm trying to think of any that if it's going to be an irritant, so I don't know, but you might get some redness from some foods if they have an irritant effect. So if it's going to be irritating, then it's going to be difficult to interpret.
Thank you. And for your opinion, what's more accurate, a skin prick test or a specific IgE blood test?
So they're similar accuracy for the most part. You will sometimes see a positive skin prick test and a negative specific IgE, and the other way around. Of course, if they're both in agreement, that's more convincing for allergy. If they're both negative, more convincing it isn't there. Difference of opinion between the two, either way round. Again, that tends to happen much more when there's intermediate results, intermediate levels.
Thank you. How long is a skin prick test or blood test valid for prior to a food challenge? So roughly a year, 2 years?
I'm not sure how long is it valid for? Well, prior to a food challenge. So I think it's, it gives you the information obviously at that point of time. If someone's allergic to peanuts and that's the diagnosis, that's a lifelong diagnosis. Milk and egg allergy can be outgrown. Sometimes the specific IgE levels and can drop off. And same with skin prick testing. So sometimes grass pollens, people still have detectable specific IgE or positive skin prick testing to pollens, even when they've outgrown their hay fever. And there is a kind of marker of previous allergy. But yes, I'm not sure that there's necessarily a validity of, yes, yeah. I'm not sure I completely understand the question, but yeah.
Sorry.
That's okay.
There's another question here, which is quite interesting, actually. It's talking about drugs that affect RAS tests. So obviously, we know with, when you do kind of skin prick testing, not to take antihistamines for kind of 5 days prior to doing the skin prick testing. Are there any drugs that affect a specific IgE blood test? Sorry, I'm just removing a spider from my table.
No, so antihistamines don't affect specific IgEs. They probably the omalizumab does, but the monoclonal Xolair used for asthma and for spontaneous urticaria. But in general, most medications don't affect specific IgE testing.
Okay, so if the kind of patient's taking those medications, what testing would you recommend rather than the specific IgE? Could you go for skin prick testing in those cases?
No, so skin prick testing would be suppressed as well. So,
okay.
But they won't. So someone on omalizumab will almost have certainly been through a respiratory clinic or an allergy clinic or dermatology for CSU before starting it. But once they're on it, you cannot test for allergy.
Okay, so you just need to go from the clinical history. What's the youngest age you can do a skin prick test?
So I'm not a pediatrician myself, but I don't think there's any limit. I think it could be done at essentially almost any age. I mean, there's not going to be a lot of. It'd be very unusual for someone under the age of 1 to develop hay fever. Food allergy isn't going to be an issue until weaning, but I don't think there's a kind of minimum age for skin prick testing as far as I'm aware. But yeah, but I'm not a pediatrician, so I've never done it on a baby myself. But it's not my clinical practice.
Thank you. So I'm just looking at the questions here. And there's another question. This one's talking about urticaria, but that's not really relevant to. It's just saying, how would you use testing to differentiate urticaria from a food allergy?
So, the main differences are going to be, whereas with a food allergy, you have episodic attacks of symptoms with a consistent trigger beforehand, or possibly a cofactor, and it's unusual to get urticaria by itself with an allergic reaction. So there'd usually be oral symptoms or GI symptoms or other symptoms going on rather than just urticaria and angioedema. And then, whereas with spontaneous urticaria, it's very often daily symptoms, no consistent trigger, will last rather than the kind of short period of time of being unwell from a food allergy. It may last for several hours or most of the day, and so it's really the pattern which tells the difference there. Those are the kind of differentiating things. You'd expect in spontaneous urticaria specific IgEs to be negative, but if there's some history of eczema or raised total IgE, you might get false positives. So it's really the history is for spontaneous urticaria usually the more useful element, and unless there's something unusual going on or something in the history to suggest food allergy.
Thank you.
But sorry, with spontaneous urticaria, there is no test to confirm spontaneous urticaria. So you can't do a test and go, now I know it's spontaneous urticaria.
And there's a request here. Could you repeat your recommended leaflet or Google search kind of the private testing or NHS testing that you mentioned? And that was the one about Sense About Science?
Yes, Sense About Science, and it's Making Sense of Allergies.
Thank you. Going on with the kind of the positive IgE allergies, this is a kind of for children with milk allergies. Can a child have a positive IgE allergy to milk if symptoms appear a few days later? So if symptoms of eczema appear a few days later?
Sorry, say it again. Can
a child have a positive IgE allergy to milk? So they can have would they have a positive allergy to milk if they have an IgE to milk, but their symptoms are eczema?
So they may not have milk allergy. You know that the total IgE may be very high. That this may be a weak positive specific IgE. You see more of it in eczema. I think it will depend on it will depend on the history, and symptoms appear a few days later. Then so in adults, it's pretty rare to have eczema driven by foods. Of course, people with eczema are more likely to have allergies, but they have allergies and they have eczema. In children, and again, caveated with I'm not a pediatrician, you do see more kind of milk and egg and sometimes some food-driven eczema, but that's not IgE mediated. Yes, I think there you're really looking at probably a 6-week trial of avoidance with reintroduction to try and work out whether the food is causing the eczema or not. But an IgE test won't tell you if a food is causing eczema. But it will tell you about the risk of anaphylaxis and the risk of severe allergy.
And one last question. If a patient did have an anaphylaxis but has recovered, for example, a day before they present to you, is it useful to do a tryptase test, or is the tryptase only useful, as you mentioned in your presentation, at kind of 0 hours and then kind of 2 hours later?
So, I mean, you can get the baseline done at more than 20 the next day, but yes, I wouldn't want, so I think capture them, because you can still, the old guidelines used to say 4 hours, and you can still sometimes see a raise at kind of, it being raised at 4-6 hours and so, but you're more likely to miss it if you're doing it later on. In a way, you may as well measure it, and then it can be interpreted in when the result is back and the time comes.
Sorry, that was supposed to be a last question, but are there any drugs that can raise tryptase to kind of muddy the waters with the tryptase level?
So, if I recall correctly, it can be raised in renal failure and possibly in MIs, but that tends to be obviously the MI will be that tends to be a milder rise than and of course usually you've got other stuff going on, ECG changes, troponins and everything else. So again, I think still measure it, and if there are renal failure, it can be interpreted, and the baseline will give you a good indication.
Brilliant. Oh, thank you so much for answering all those questions. You've been certainly grilled this morning. Thank you very much.
Yeah.
A fantastic presentation as well. Thank you.
Thank you.
And thank you to all for watching. We're now going to go to the break, and we can reconvene again at 11:30. Thank you. Hello and welcome back to the second part of the Masterclass webinar by AllergyUK. Our next speaker is Anne McMurray. She's a specialist paediatric asthma nurse from NHS Lothian in Scotland, and she'll be talking on the practical management of asthma and allergic rhinitis. Remember to send in your questions via Slido on our webpage or via the app with the hashtag AllergyUK 1606. That's hashtag AllergyUK 1606. Over to you, Anne McMurray.
Thank you, Margaret. So, as Margaret said, I'm a paediatric asthma nurse specialist in Edinburgh, so I'm going to take you through some of the practical steps to manage asthma and allergic rhinitis. What I'll do is I'll go through my slides first, finish off with the take-home messages, and then come back to full screen so I can demonstrate some of the techniques for spacers and nasal steroids. So what I want to cover today is basically go over the pollen calendar, think about some of the practical tips on reducing pollen exposure, look at the non-pharmacological treatments which are available, think about nasal douching, eye drop technique. I'll come back to the nasal steroid and inhaler technique, and then provide some take-home messages along with web links, and we'll have some questions. So I think one of the most important things really to address with your patients is to think about what their actual trigger is for hay fever. And we can see from this pollen calendar, which is available on the Allergy UK website, that pollen is present in the air most of the year. So it is important that you take some time to try and identify what the possible trigger factor could be. As you can see from this, we typically think about the early flowering trees in March time, moving on to grass pollen towards the start of the summer, and then think about the weeds towards the end of the summer into autumn. I think one of the really important things to think about is if you know and are able to identify the trigger factor for your patient, is to advise them to start treatment at least a month in advance if you know that symptoms are typically problematic. So identifying pollen counts, well, there's lots of practical ways to do this. So we're very fortunate now to have a number of apps available for our mobile phones. And the weather forecast, which is on the news after the news in the evening, provides pollen count updates as well. And as you can see, I did this quick search online for a pollen count in Edinburgh as I was preparing this talk. And you can see that it would have alerted me that the pollen count for tree pollen was high, grass pollen was high, but for ragweed, it wasn't present. So I think just looking at the pollen count on a daily basis may help your patients plan for activities or perhaps holidays. Same, we're all taking part in staycations this year, and obviously pollen counts will vary region to region. When we think about the rain, there is a bit of conflict in information which is provided online about the benefit of rainfalls. So there is advice that a kind of mild to moderate rain shower can actually help clear the air, but a heavier rain shower can in fact crack down onto the ground and disperse pollen back into the atmosphere. So we just need to be careful around the times of rain showers. Which brings me on to thunderstorms. So for those who were watching the weather forecast yesterday evening, you'll see that the UK is on alert for thunderstorms over the next couple of days. So thinking about thunderstorm asthma, this has been a known trigger factor for patients with asthma, which sadly has resulted in asthma deaths. So the theory behind this is that during the day, the whole pollen grains get swept up into the clouds as the storm starts to mature. Then the moisture in the clouds breaks up the pollen into smaller particles, and then the dry, cold outflows carry pollen particles to the ground level where people inhale them into their airway. And if our patients are typically affected by pollen, this overwhelming exposure can lead to chaos. So it is good to see that some clinicians on Twitter and some of the social media pages will actually post alerts advising our patients to make sure they are carrying the reliever inhaler with them, but also that they're addressing the more important factor of not forgetting to take preventative treatment. So some of the practical advice, it's very difficult to try and tell people to stay indoors, but we know that typically pollen counts are at their highest between 5 a.m. and 10 a.m. in the morning. The peak is around midday, and then the pollen levels tend to fall in the afternoon and early evenings. So ideally, if your patient is someone who enjoys maybe going out for a run, you may want to advise that that would be something that they should avoid in the mornings and may do in the early evening. So we know that pollen typically stays on your clothes and in your hair, and pollen is virtually indestructible unless it's wet, so it will stay on your clothing all day. So you may want to advise your patient, if they're someone who showers in the morning, they may find benefit from actually showering in the evening as well to rinse that pollen completely off them. Although, it is really difficult to keep those windows closed. We don't want the pollen coming in, so the windows need to be closed overnight and kept closed during the day as well to try and reduce that exposure. Some of the other things, often it can be a good reason not to have to mow the lawn, but we know that that would trigger off symptoms for patients. So really, if they are pollen sensitive, then we wouldn't want them to be mowing lawns or raking leaves if at all possible. For adults and for children, we would advise them to wear sunglasses which wrap around the eye if their eyes are affected by pollen, and also to think about wearing a hat if appropriate. We can often look at wide brimmed hats, as the picture in this slide shows, and for children and men, they may find, or women, wear a peak cap as well. So just whatever suits the person who is wearing it. And then again, it's one of those things, isn't it? We all want to get our washing outdoors whenever it's dry and windy, but we know that that will just be exposing the washing to pollen, which then our patients will inhale whenever they're in their bed. So again, unfortunately, this would need to be dried indoors. So there's chat about in the car. So again, if possible, keep those windows closed. And some cars, some of the more modern cars, are actually fitted with pollen filters. But it would be a good idea to keep the windows closed, and a lot of the newer cars have aircon built in to keep the car cool. I think we've certainly seen an increase in families purchasing pets throughout the pandemic, but we know that pets are particularly prone to carry pollen on their fur and on their hair. And obviously, as a pet owner, lots of people cuddle into their pets or stroke them, which would just be transferring the pollen across to the ones that are affected. So, if possible, and if that pet will allow, we would want them to have a wipe down with a damp cloth just to remove pollens. So we've obviously heard from our speakers earlier on about the pharmacological management of allergic rhinitis, but thinking about what could be done as a non-pharmacological treatment, well, we know that some of the nasal balms are particularly helpful just to reduce the pollen getting accumulating inside the nostrils. So you could use something as simple as a petroleum jelly just inside the nose, and that is purchased really cheaply and over the counter. Or there are some nasal balms which are marketed for hay fever, such as Haymax, which has got a light scent, and a small tub of this lasts for quite a number of years because it goes a long way. We've also seen some of the facial wipes, which are now available in the pound shops and cheaper chemists. And they're around about £1 for a pack. Again, just really for wiping down the face and inside the nostrils during the day whenever people are out and about. So you may have heard people talk about the effects of local honey, and it's unfortunately a myth. So local honey tends to contain the heavy flower pollens, and we know that the pollens which affect those with hay fever tend to be grass and tree pollens, and unfortunately the bees don't visit the grass or the tree pollens. So it tends to be that local honey is not helpful. However, if your patient reports back to you that they find it to be beneficial, then there is absolutely no problem continuing with that. So nasal douching, it's a bit of a love it or hate it, but certainly patients who have used nasal douching report huge benefits if it can be tolerated. So ideally, it should be used before the nasal steroid is used, whether it's a once daily nasal steroid or twice daily. But it can also be used at different times throughout the day whenever the patients are feeling nasally congested. So in Scotland, we have Sterimar available on prescription. You may want to check with your local pharmacy or prescribing group whether or not it is available on prescription in your local area. Techniques are very different using Sterimar versus one of the purchased nasal douching mechanisms, which is the one that I've suggested is Neilmed. However, there's other preparations such as Sanusol salt. So each of them just really whichever the patient prefer, and it may be based on cost as well. So for the Sterimar spray, there's a very helpful video on their website, but the head needs to be maintained in an upright position. Only one spray of the Sterimar should be instilled, so that's about a second of pressing down on the little nozzle at the side, and then your patient would press against their nostril quite briefly and then would be encouraged to blow their nose. And they can use that anything between 2 and 6 times in a day. After each use, the nozzle should be removed from the top of the tin. It should be rinsed and it should be dried. For the Neilmed preparation, this comes in with sachets, which need to be made up with cooled boiled water and left to just make sure that it's obviously not going to burn the patient, so it should be left for quite some time, maybe made up the night before and left for use in the morning. So with this, it is a squeezable bottle, and your patient should be advised to lean their head over the sink and pop the nozzle inside the nostril, press up into the bottle, and you should aim to kind of squeeze about a third of the bottle into the nostril, and it should go in one side and out the other, and the mouth should remain open throughout. And then at the end of that, your patient would be advised to blow their nose. So it can take a wee bit of practice, but there are certainly training videos available online, and it should be considered. So eye drops, one of the things that often patients do wrong is if they're prescribed more than one drop at a time is to put both drops in at once. However, only one drop should be instilled at a time. So important to wash the hands first. If there's any discharge from the eye at all, this should be cleaned away with cool boiled water and a little pad. The eyelid, the lower eyelid should then be pulled down. The one drop should be put in, and then the eye should be closed and should remain closed for a few minutes. So some of the eye drops we know need to be used 4 times a day, some can be used twice a day. So it may just be whatever is appropriate for the patient. If they feel that they're not managing well with one, I would encourage them to come back and discuss further what other options are available. And certainly from an adherence point of view, getting children to take eye drops 4 times a day can be very challenging. So you may want to just look at a medication which is suitable for twice daily dosing. So I will come back to the practical steps, but just to make you aware, there are training videos available and little diagrams such as this one to the right. This is the instructions from the BSACI guideline on the management of allergic and non-allergic rhinitis, but I will come back to spacers and nasal steroid technique. Just before I do that, I'm just going to give you a few take-home messages. I think it's really important to discuss through with your patients what their trigger factors are, both for their allergic rhinitis, so pollen triggers, but also for asthma. So it may be that their asthma gets worse at a particular time of year. So just having those trigger factors documented and making sure that the asthma action plan is adjusted for seasonal variation. Practical steps are really important, and unless the patients follow practical advice, they'll find that medicines alone will not relieve symptoms. So they need to follow the practical steps as well. We know that pollen is indestructible unless wet, so more frequent showers or washing out of the nose and the face may prove beneficial. And I think it's really important just to let your patients experiment with treatments, because we know that not all treatments suit every patient. So they may need to play around with different nasal steroids or different eye drops, different non pharmacological ways of managing things, maybe encourage them to try nasal douching. But it is important they find something that works for them and something that they're going to manage to be adherent with. And of course, really important that they know how to administer their medications correctly, because if they're administered incorrectly, they won't find true benefit. So web links which are available. So on the Allergy UK website, there's a really helpful leaflet on the management of rhinitis in children. And obviously there's one for adult patients as well. We are encouraging everyone to look at inhaler technique, and there are training videos available. We know that during the pandemic, it has been a huge challenge to make sure that we are reviewing our patients at least annually and going over inhaler technique. And it is difficult when I know a lot of people are doing phone reviews. But wherever possible, try and review your patient's technique. We know that it slips over time, and we know that we've gone over good practice, and they'll come back to us the next time and maybe have added in a few extra steps or removed some important steps. But the training videos are available online. They have all been made to a national standard following advice from the UK Inhaler Group, so that hopefully everyone in the UK is teaching to the same level. We've also obviously got our Allergy UK website, which is a host of really helpful information that you can signpost your patients towards. And of course, there's the BSACI guideline, which is a free access guideline on the management of allergic and non-allergic rhinitis. So just before I come to questions, I'm going to go to full screen so that I can go over inhaler technique and nasal steroid technique. So I'm going to demonstrate the small volume spacer, the aero chamber, but as you're aware, there are a number of spacers available in the market. There's a large volume spacer, the Volumatic, and there are a number of small volume spacers such as the Able spacer or the Easy chamber, but all of them go with the same kind of advice that we are, which I'm going to use and demonstrate for these devices just now. I think one of the most important thing is making sure that you've got an age appropriate device. We see a lot of children slip through hospital admissions using face masks, even as old as 11 and 12. So we would obviously advise that children are using mouthpieces from a younger age. So if I just go over the small air chamber first. So I'm going to demonstrate the yellow one. The one that I am demonstrating is one of the newest devices, which has got an anti-static coat, which will make a difference for washing instructions, but not technique. So first things first, we need to shake the inhaler first, then remove the dust cap, and then advise your patient to look inside the inhaler. And that's just to make sure that there's not any dust or anything else that could easily be inhaled. The inhaler should then be placed in the flat end of the spacer. And for children, we would recommend this air chamber is used for children up to the age of 5. The air chamber or any spacer needs to be in place first before the dose is placed into the holding chamber. Okay, so for any of you that work with children, you'll know that there are often challenges with small children getting them to take medication. And if you were to place the spray into the spacer, although it is held there, the optimum time of inhalation is the first 10 seconds. So if you're fighting with a toddler to get the spacer in place, you may have lost the active part of the drug. So spacer always in position first, and you see it should be at a horizontal level. If the child's in bed, you can tilt downwards. It should only ever be one spray in at a time, and you should watch the little valve move above the nose, and you can see it activated with my hand. It should move 5 times. Sometimes we get asked whether or not, if a child is crying, whether that will increase drug delivery. But for any of you who have watched children crying, they tend to breath hold, so they won't actually see they won't actually get delivery of the drug at that stage. So we want the child to be calm, and it may be for the first time that you're going to have to take some time encouraging the child to take the spacer. It's only in position for 5 breaths, so you may need to do a lot of encouragement to take get a younger child to take their inhaler in the first instance. We don't advise wrapping children up because that is a form of restraint and can be associated with a negative feeling towards taking a medication, which is going to be beneficial. If you're giving a second dose of the inhaled medication, you need to wait for 30 seconds. And the reason for that is if you press down in the canister, it actually alters the temperature inside the canister. It needs to stabilize back to room temperature before the particle size would be the right size for drug inhalation, and that takes 30 seconds. And that is something that we often pick up as an issue with the use of spacers. So moving on, we would always recommend a mouthpiece for a child aged 5 years and above. I'm just going to demonstrate the green air chamber, but if any of you are familiar with the different ones that are available, there's also a blue one for adult patients. I suppose the only difference with these anti-static coated spacers are they have actually been designed for tidal breathing, so they're a very comfortable device for children to breathe in and out of. So again, exactly the same technique beforehand. You're going to shake the inhaler first, check to make sure there's no dust or anything inside the inhaler. And this time you've got a little whistle just above the top of the plastic bit at the end. The whistle is there to let you know if you've taken too fast or forceful a breath, which would cause the medication to be deposited at the roof of the mouth or the back of the throat. So it's an indication that the child needs to take a more gentle breath. And obviously the whistle is also present in the blue spacer as well. So you would be shaking the inhaler, popping it in the flat end, as I said, one dose in, and then it would be 5 gentle breaths in and out, watching the little valve move above just above the nose. Okay, if you heard this noise, this is the whistle. If you heard that noise, you would obviously advise your patient to go more gently. So washing instructions during the pandemic, we have been advising our patients to wash the spacers a bit more frequently. We used to advise once a month. We are advising once a week at the moment. For the anti-static spacers, they can be washed in the dishwasher just by taking the device apart and placing it in the top part of the dishwasher. If your patient doesn't have a dishwasher, then it can be washed in hot soapy water. It should be left soaking for about 15 minutes and then brought out. We don't advise rinsing the spacers. For those that have been anti-static coated, they can be dried. For those that haven't been, they need to be drip dried. And just a reminder, this can take a number of hours. So ideally what you would be asking your patient to do is wash it in the morning after they've had their dose or wash it in the evening. Spacers need to be replaced annually, and for those caring for children, schools will request some spacers to have available for children in school. It will depend, the number may depend on whether or not your school has adapted the emergency inhalers in schools policy, and if they have, they may ask just for one spacer. We know that children typically spend a lot of time in different places, so it may be that they need some for being at mum's house, maybe some at dad's house, may ask for some for after school clubs. So I think it's just if you're finding that a lot of prescriptions are coming through, requests, you may want to just chat that through with your patient. And obviously, if they're not being used as regularly as daily, then they will last longer than the year. So you may find that school may only need one for a few years before being replaced. So just moving on to nasal steroid techniques. So there's a number of different devices available. Now, unfortunately, it's very difficult to get a nasal steroid placebo device. So what I've done is just purchased a cheap one over the counter, and that's what I tend to use for demonstration purposes. So important just to be aware, different devices can expire after being opened before they actually reach the expiry date. So important just to kind of look out for that with your patients, because some of them only last for 2 months whenever opened. So you would want them just to check to make sure. So to use a nasal steroid, you want to just kind of clean the nose out just beforehand. If you've managed to convince them that nasal douching would be beneficial, they should do this first. But to use it, you're going to shake the device first, and then you're going to pop the nozzle inside the nose. Now you're going to use your right hand for your left nostril and vice versa. It's really important to get the head in the correct position. So I usually say is look down like you're on your mobile phone or reading a book. So head would go down. You're going to use your right hand for your left nostril, pop it in, scoosh, and a very gentle sniff. Okay, so what we often see whenever patients are using nasal steroid is they take a big breath in and the medication goes to the back of the throat, down into the tummy. They get a nasty taste in their mouth and they are less inclined to use it. Other problems that we often come across is that if your patient is just popping it directly using maybe the right hand for the right nostril, they often point towards the septum or just point straight up. And often this can lead to irritation inside the nose and can lead to nosebleeds. And we know that if your nose is bleeding or sore inside, you're less inclined to use your nasal steroid. So we know by using the correct technique of head down, opposite hand for opposite nostril, you reduce the risk of nosebleeds by about 80%. And as long as they're not taking big breaths in and snorting medication down into the tummy, adherence with treatment is often good because our patients do see clinical benefit. So I'm just going to finish there. I think Margaret may have a few questions for me. But as I said, the links are really helpful that I've provided on the end of the talk today. So please take time to go through them, and any questions, I'm happy to answer them just now.
Oh, thank you so much, Anne, for a fantastic practical demonstration you did there, all the self-help tips. It's fantastic. Right, we have got some questions coming in for you. So you ready?
Yep.
First one is, how easy do you think it would be for an asthma nurses, GP practices, to ask about symptoms of allergic rhinitis?
So we know about 80% of patients with asthma will actually have allergic rhinitis. So it should be part of your routine review. So I always ask my patients about runny, blocked, stuffy, sneezy nose, out with colds. And we know that actually if the child or adult has got unstable rhinitis symptoms, this will actually impact on their asthma control. So it should be something that's part of your day-to-day routine.
Thank you. And there's a question here that said, you said 5 breaths for inhalation. Has this changed from 10? I think the 10 might be the rescue medication.
So the number, I think the person's referring to the number of breaths in and out. So I think that was a bit of a old wives' tale. So the technique for the small air chamber has always been 5 breaths in and out, but practice has varied throughout the UK, and that's what I've said about, important to have a reflection on these training videos, because 5 breaths in and out has been the recommended number of breaths per puff for quite a number of years. But we did a massive revamp in our local hospital last year because technique had varied so much, and parents were coming back and telling us they were getting mixed messages. 5 breaths is all that is required. And in fact, if you read some of the information on the leaflets from the different companies, they do recommend as little as 2 breaths in and out. But for consistency throughout the UK, we have asked for 5 breaths in and out for large and small volume spacers.
And there's another question here. What age can a child be diagnosed with asthma?
Well, there's the question, isn't it? So typically the guideline that we follow in NHS Lothian, and this can vary, we follow the ERS guideline for the management of preschool wheeze, which suggests that children under the age of 5 are diagnosed with either episodic viral wheeze or multi-trigger wheeze. So typically we would say 5 years and above. Now, there's just been a new document released from the European Respiratory Society on the management and diagnosis of asthma in children, and they're using the cutoff from 5 years and above. So, with confidence, you should be able to, with good history taking, trial of treatment, and review, you should be able to make an accurate diagnosis for children 5 years and above.
Brilliant. And there's one here about symptoms. So can people get pains in their chest from asthma? And is that a normal symptom? And what symptoms can you get with asthma?
Yeah, so the typical symptoms that are reported are cough, wheeze, chest tightness, and difficulty breathing. And I think sometimes it's difficult to tease out, especially with a nation of deconditioned people, because we've not been doing any activity for the last year or reduced activity, about breathlessness. So often people think, oh, I'm breathless, that's a sign of asthma. But actually, what we're looking for is more so difficulty breathing. So the chest pain that the patient may be reporting could be chest tightness. And again, it's maybe just a matter of teasing that out a wee bit more. I often talk about, do you feel like someone is lying on your chest and squeezing down? That's the kind of pain that people with asthma would often say is the kind of chest pain that they're experiencing. We know, however, that chest pain can come from other reasons, so it may be infection. So if the patient is complaining of chest pain, it may be something to be explored a wee bit further.
This one's to do with kind of pregnancy and breastfeeding. So can the patient take their asthma medications while pregnant and breastfeeding?
Yes. So there shouldn't be any change in your asthma therapies throughout pregnancy and breastfeeding. But what we do know is that actually asthma control can change throughout pregnancy. So we know the key times would be onset of periods, pregnancy, and menopause. You can actually either get a huge benefit from or improvement in asthma control at those times, but equally so you can have a marked deterioration. So you should always discuss your asthma therapies or any concern with your practice nurse or GP, just to let you know that biological treatments, which are the injectables such as omalizumab and mepolizumab, initially whenever these medications were being used, it was a contraindication if you were pregnant. However, now what they're saying is it's very much risk benefit. So if you felt that with removing these medications from your routine, your medicine management, you would have a decrease in asthma control, then that wouldn't be good for the mum carrying a new baby. So yeah, so we're seeing a huge kind of knowledge base with pregnancy at the moment. So yeah, it's good news.
And there's another question here. Can asthma present without wheeze?
So yes, it can. So wheeze is a symptom, and wheeze often is only heard on auscultation, so that's listening with a stethoscope. And patients may not be able to know what actually wheeze means. So they did a really good study, and quite an old study now, carried out in London by Sheila Mackenzie, which actually asked patients to record perceived wheeze and ask clinicians to review it. And there was a huge discrepancy between what actually wheeze meant. So I think it's really important. Your asthma guideline says that asthma can be diagnosed with 2 or more of the symptoms of cough, wheeze, chest tightness, and difficulty breathing. And I think one of my hugest learning curves was whenever I interviewed a mum whose daughter had died of asthma. Her daughter only presented with cough and difficulty breathing. She didn't perceive herself to be wheezy and very sadly died of an asthma attack. So I think it's something to be taken seriously.
There's a question here about kind of the air chambers or the volumatics. It says, until what age do you recommend using these?
So I would recommend using a spacer forever. So regardless of what age you are, I think we know that meter dose inhalers are typically used incorrectly. So a lot of our patients will see them shaking their inhaler sometimes, popping it into their mouths, doing a massive suck up, will or will not hold their breath. So we know that actually a lot of that medication is just lost, ends up in the tummy. So I would recommend a spacer from infancy to old age.
And here's another one for kind of, obviously, if somebody's having an asthma exacerbation, how many puffs are advised? And what symptoms are we looking for to advise parents on when to call 999 and get medical advice?
So there's a huge debate out at the moment for any of you that follow Mark Levy either on Twitter or have attended any of his lectures. So the licensed dose in the BNF and the BNFC for salbutamol is 1 to 2 puffs. But we know typically in practice within the UK that we have altered practice and we are now using very large doses of salbutamol through the spacer for treating acute asthma. Now, locally in our centre, we use 4 puffs of salbutamol 4 times a day for 4 days whenever children have got colds. And we have found this to be of huge clinical benefit to our patients. But that's very much kind of, I would follow your local guidance in your local area. For the signs and symptoms of an asthma attack, so what we're looking for, there's a trigger factor for children. So symptoms will not go from being asymptomatic to having an asthma attack without some kind of warning, unless, of course, they're having anaphylaxis. So thinking about warning signs, you will find, first of all, the kind of activities of daily living. So this is what I tell parents to look out for. How is it affecting their child day to day? So are they able to speak to you in a full sentence? So if it becomes a phrase or less, so single words or unable to speak, those are all indications of getting urgent medical review. They may find it too difficult to eat and drink because of breathlessness. They may find it difficult to walk. And whenever they're in bed, they may find it difficult to lie down and get to sleep because they're agitated. So all signs of hypoxia. Other things to look out for is breathing from the tummy. And tracheal tug. So we get parents to look for that. But whenever you see patients often in clinic rooms, they're all bundled up. So it's very difficult to see what they look like underneath. Just getting them to remove a layer, having a wee look at the tummy for you. So tummy muscles, at the throat, and then obviously the signs of coughing and wheezing. If they've got a peak flow meter available, that would be really helpful because it's our only objective measurement that we can do to measure how things are. So that's what I would recommend. The other thing that I am now talking about a lot with my families are if you have got, as a parent, if you have got a gut feeling that something isn't right and you need to get your child checked out, you should do this and it should be day or night. Don't ignore that.
Thank you. And this is the last question. I'm aware that you are in paediatrics, but are there any contraindications for patients with asthma to having the COVID vaccine?
So no, so we're highly recommending our patients with asthma getting their COVID vaccine. There was a lot of kind of misinformation with vaccines initially where they said, everybody with asthma to get it as a kind of priority 1 to 9, then it changed for different doses. But we are highly recommending every patient with asthma getting their vaccine. I suppose our biggest learning curve, however, has been how COVID has affected children. So we were really worried with our patient cohort how COVID would actually affect children. But what we find is it is not causing any increase in wheezing. It's not a trigger factor for an asthma attack. But we are highly recommending every child with a new onset cough, regardless if the parent thinks that that is their asthma, to get a COVID test. And I saw on the news last night from the Zoe team that some of the latest symptoms coming through, really worrying, are sneezing, runny nose, and sore throat. And we're in the middle of a hay fever kind of time. So I think it's just going to be really challenging for us all. So I just would recommend a COVID test wherever possible, but definitely COVID vaccination. And we're just waiting to hear what's happening with children. We're still waiting for the JCVI to make a decision on 12 to 15-year-olds.
Oh, well, thank you very much, Anne McMurray. That was absolutely fantastic.
Thank you.
That's some great advice there. And we'll now move on to our next speaker and talk about cat allergy and its management. And this is Amina Warner, who's the Head of Clinical Services at AllergyUK. And remember to send in your questions via Slido on our webpage or via the app with the hashtag AllergyUK1606. Over to you, Amina Warner.
Well, good afternoon, everybody, and thank you very much, Margaret. We've had such great speakers that they're hard acts to follow. And I'm at that stage where it's just before lunch, etc. So brilliant talk by Anne. Thank you very much. And so I'm going to talk to you about cat allergy and its management. And you think, well, why cat allergy? It's the first time that Allergy UK has actually put on information specifically about cat allergy and its management. So first of all, let's talk about what actually is cat allergy. Well, from today's talk, you will know now that allergy is an abnormal response. So cat allergy is an abnormal response of the human body's immune system for the allergens that is produced mainly in the salivary glands and skin of the cat. So what do we know about the immune system? We know that it makes antibodies, and it's our defense mechanism. It protects your bodies and it tries to fight off bacteria, viruses, parasites, etc. So if a person who has allergies, their immune system mistakes an allergen for something harmful, it activates that defense system and it starts to make antibodies to fight it. Now, when it's something that's quite harmless, such as in this case cat, and the proteins in the cat, mainly the salivary glands, etc., the body makes a specific immunoglobulin, and you will have heard from Tariq's talk when he talked about diagnostic testing and about specific immunoglobulins that we look for in testing. Well, the body makes these specific immunoglobulins to this cat allergen called specific IgE to cat, and the major allergen that all cats produce is called FeLD1. And you will know from the talk that Tariq gave about the component resolved diagnostics that this is a way that we look at certain proteins and break them down. So as you will know, Fel is feline, so FeLD1 is the major cat allergen. Next slide, please. So when the allergen produced by the cat is then breathed in by people in the house, and some susceptible people, they don't necessarily have to actually be in the house, but they might have a susceptibility. So, well, again, Tariq was talking about atopic family history of eczema, asthma hay fever. Often these types of people will have very high circulating IgE. So when you measure the total IgE, sometimes they're very high. And so we call that atopic individuals. So they have a higher prevalence and chances of having allergy, and they can become sensitized. But this process can also happen to people who are not atopic, and they can become sensitized to the cat allergen, and they can develop symptoms. And these symptoms to cat allergens are what we call cat allergy. Next slide, please. So what are the allergens that are implicated in cat allergy? Well, I've told you about one, which is FeLD1, which is a secretoglobulin. It's the dominant cat allergy, and it's found in all cats. And that's regardless of whether the cat has long hair, short hair, what breed of the cat, whether it's male or female. It's found in all cats as the major cat allergen. So not surprisingly, in our testings, our specific IgE testing to cat and also our skin prick testing, FeLD1 is predominantly in there. So that's really important to note. There's been about 8 cat allergens that have been characterized, and really there are just 3 that we talk about of any major clinical significance. But the one of most clinical significance is the FeLD1. So it's secreted predominantly by the skin, the sebaceous glands, and it can become within the hair and the fur of the cat. It is also secreted in the salivary glands as well. And to a lesser extent, the lacrimal and the anal glands as well. But what do we know about this very important protein, this FeLD1? Well, we know that it can readily become airborne, and it's very, very small. It's a very small protein particles, so can be problematic, as you'll see a bit later in the presentation. Next slide, please. So there are these other proteins as well, FeLD4 and FeLD7, predominantly from the saliva, and then there's a minority that is a more minor allergen, is FeLD2. So because that one's not secreted to any degree, we tend not to worry about those so much. But when we do component resolved testings, we can break all those proteins down and look at some of the things. And this is important if somebody's going for something like immunotherapy. Next slide, please. So what is the problem? Well, we know in COVID how important our animals have become to us. You know, there was an increase in people getting animals, etc. So what is the problem? These beautiful little feline creatures, what are the problems? Well, we know that cats are very, very popular companion pets. If anyone's ever had a pet, they will know exactly why they are so popular. There is nothing more relaxing, in my opinion, of having a cat on your lap and stroking the cat. It has its therapeutic benefits, but not to people with allergy. In modern times, we're spending nearly 90% of our time indoors, and with the COVID and all the lockdown restrictions, etc., that we endured, you know, that time was hugely significant, and we were spending nearly all our time indoors, apart from just popping out for essential things. And it's estimated that about 25% of people in the UK actually own a cat, and of those, as many as 35% of them who own a pet may suffer some form of allergic reactions to the animal. So that very beautiful, animal that they might have in their house, their cat, maybe it might not be quite at the beautiful sanctuary environment of your home and have that beautiful experience. It may become unfortunately not quite so nice an experience for some people, and so that can be very problematic, and as we'll see later on. Next slide, please. So we do know that pet allergy is the second most commonest cause of allergy in the home. You'll know that the first being house dust mite. So pet allergy is hugely significant when we talk about indoor allergens, and in asthma, in things like asthma and allergic rhinitis can be hugely trigger factors. So allergy to cats are the most common animal origin allergy, and not just in the UK but worldwide can affect approximately 1 in 5 adults, so hugely problematic. We know also that allergy to cats is twice as common as allergy to dogs, and for some poor individuals it's actually possible to be allergic to both. And so often if it's somebody who's had those type of problems from a young age, that's almost a deterrent not to have pets when they go and leave home and have their own adult life. That's a barrier sometimes to some people forever having pets in the home. Next slide, please. So why is cat allergy significant? Well, we do know that allergy to cats is a major risk factor for the development of asthma and allergic rhinitis, and there has been quite a number of very significant research evidence about that. Nearly 30% of people with asthma have been found to have had an asthma attack brought on by cats, and often these people don't necessarily have to have cats in their home. As I say, they might be sensitized to cats, develop cat allergy, have gone on to in adult life and not had cats in the home, and then they've come into contact with cats either in their working life or in their social life or just by chance, and they can have an asthma attack brought on by those cats. We do know that cat allergens are very long-lived and very persistent, so this is what you would term as a persistent indoor aeroallergen, and a persistent aeroallergy to cat allergy especially if the cat is actually in the home as well. So FeLD1 is very sticky, so it's very light in weight, so it can easily become airborne. And we know that I've just mentioned about the very small protein structure, so that means that when it becomes airborne and it gets and it's breathed up into the lungs, it can go quite deep and cause that inflammation deep down into the lungs. And if somebody hasn't got a cat in the home but they go into contact with somebody who's got a cat and they are cat allergic, that deep inhalation of those proteins deep into that lung can cause a significant inflammation and an asthma attack from that process. And people have said to me in the past that it can completely floor them when they coming in contact with this beautiful little cat, and the tightness they feel on the chest and difficulty breathing is so significant for them. Next slide, please. So it's such a sticky protein that it sticks to hair and clothing and gets in all sorts of places, even behind radiators and skirting boards. And I've heard it said that it's almost like glitter. And if any parents out there who know about glitter and young children, they take the top off and the glitter just literally goes everywhere, and it takes ages to clear up a glitter mess. So cat allergen can be quite sticky, and it gets everywhere, literally. And so they're not always places that we clean on a regular basis, and so it can be a real nuisance. It can last for many, many months without breaking down. There's research evidence that it can last up to 2 years before all traces of cat allergen has gone, even though somebody might get rid of a cat. So that's really important to note. So cleaning of a house is really, really important as well. And when we talk about some of the management techniques, we'll go into some of that. Although those current types of management techniques are often very time consuming and very, very laborious as well, when you're trying to manage that level of cat allergy day in, day out. It's often transported out of the home because, as I say, it's very, very sticky, so it can stick on hair, clothing, and etc. And often it's found in schools. So little Johnny, who might have cat allergy and not a cat in the house, might sit next to little Freddie, who's has got a cat or a couple of cats in the house, and he's got all that allergen over him. So little Johnny might have some symptoms of allergic rhinitis or asthma when they're in close contact with each other. So just a thought when you're taking clinical history from people about those type of exposures. And we do know from research that both pollution and exposure to allergens from domestic animals such as cats are more likely in very overcrowded environments, and often inner cities in particular have these type of environments, and they have resulted in increased incidence of diseases, and all the evidence is telling us that can be very, very problematic as well. Next slide, please. So the incidence of cat allergy has been steadily increasing. I don't expect people who have cats, that to stop increasing, because people are, in UK, people love their pets. Again, in the way we are living, etc., is incidences of cat allergy has been steadily increasing, and not just exposure, but also pollutants also has an impact on the problem with cat allergy. Although you might have heard of these hypoallergenic breeds of cats, and there have been lots of studies about that, lots of experiments to try and breed these types of hypoallergenic cats. There have been some claims about hypoallergenic cats, but to the very best of my knowledge, and I've done quite a bit of background looking and research on this, there's no truly hypoallergenic breeds of cats. So it's wrong to just say, if you had a different type of cat with very little hair, like the hairless things like Sphinx or something, you wouldn't get any cat allergy, and that's not true, because all these cats produce this FeLD1. There has been some suggestions that very early exposure to cats, like in infancy, etc., protect from cat allergy, but the evidence really isn't clear on that, and so that's not something that's fully understood or really taken as yes, get a cat, expose a child to cat in early infancy, it will protect from cat allergy later on. That's not something that can be recommended. The prevalence of sensitization to cat allergen by skin prick testing is reported to be about 8 to 15% in studies, and that's worldwide. But we do know that is increasing, and so evidence is showing us that it's approximately doubled in the past 30 years. Next slide, please. So signs and symptoms of cat allergy. Here you can see a very typical picture of a child who truly, their quality of life increases with just having an animal around them. Lovely, lovely picture, but sometimes we know that some of the symptoms that children and adults get from that lovely exposure to the cat can be hugely problematic to them. So many patients who become sensitized, they develop this specific IgE to the cat allergens, but very interestingly, and we do not know the reasons why for this, that they develop no symptoms on exposure to that cat at all. So that little girl might get away with being so close to that lovely cat and enjoying her childhood, maybe being sensitized to cat allergen, but not developing any symptoms whatsoever. And that mechanism, why it does that, it remains unclear, and we cannot predict who will develop cat allergy and who won't. That's something that we can't predict, but we do know that they might be sensitized to it. So patients that are sensitized to cat allergens, like all allergic patients, when they become sensitized to them and then they suffer symptoms on exposure to that allergen, then this is what we will call cat allergy. Next slide, please. So some of the symptoms, like other symptoms you will have heard from Glennis's talk this morning when she talks about allergic rhinoconjunctivitis, those hay fevery type symptoms. So people think hay fever, oh, grass pollen, but a lot of airborne allergens can give these types of symptoms, and cat allergy is one of those. So the itching, often allergy comes with itching. It's itching of the nose, it's itching of the eyes. It's can be itching of the mouth, the roof of the mouth, the oropharynx. It can be itching just in the ears even. A lot of patients will tell you that itch can be uncontrollable. So it's long-acting, non-sedating antihistamines often take some of that itch away. So itching is a real predominant feature in allergy, and sometimes redness, running of the eyes and nose, especially when people are rubbing their eyes as well, and often you can see the conjunctiva quite red and inflamed looking, and that constant streaming and itching is very, very uncomfortable for people who have this. And so when they're in contact with cats or come in contact with a cat allergen, the cat doesn't necessarily need to be completely in the room, as I've given you an example of little Johnny that sits next to little Freddie who's got cats. That is enough sometimes to cause some of these symptoms. So coughing, nasal congestion, postnasal drip. Often when you get that nasal congestion, you get that nasal blockage, the drip of the mucus down the back of the throat, the postnasal drip, is really uncomfortable. Sometimes it comes out the front as like a clear rhinorrhea, but other times, people talk about this horrible feeling of mucus at the back of their throats. Sometimes it can cause tightness of the chest, that bronchospasm from that deep inflammation that might be going on down in the lungs, and sometimes people can have difficulty breathing. Sometimes that can become an acute emergency where they really do need to seek medical help. But anyone who's got difficulty in breathing and asthma, if their usual medication of their inhalers, etc., is not working, then they need to seek urgent medical help. And it can exacerbate existing symptoms of asthma. So people who have cat allergy, sometimes what they report is that they had maybe some symptoms when they were living at home with a cat. They no longer have a cat. They might go off to university, but when they come back into the home and the cat's there, then they can have these quite significant symptoms, and it can exacerbate asthma, etc. So that's something for people to be aware of. Next slide, please. So sometimes people can get skin rashes as well when the cat might brush against them, etc. Then get urticaria, etc. Some people have even said that sometimes it can exacerbate their eczema as well. And some people say that their symptoms of cat allergy from the tightness of the chest that might be relieved by their bronchodilator, that over the next few days they can get more, sort of their asthma can become worse, and that's more of the delayed inflammatory side of it. And we talk about a symptom threshold, and so when we talk about symptom threshold, that we have people who don't have symptoms all of the time, but maybe when there is that threshold has been breached and reached, then that's when they become symptomatic. And so it might be that somebody who might, and we'll go into the management techniques on this, but it might be that somebody, say for example, is doing rigorous cleaning of their environment. They're not letting the cat into the bedroom, etc., and they actively manage all their symptoms, and then the cat is still in the house, etc. The cat finds its way into the bedroom, hasn't been cleaned, etc., and that threshold has been breached, and then they can get symptoms. That type of thing is what I'm talking about by their symptom threshold. Or it could be by having being allergic to other allergens as well on top. So it might be that they have lots of different things they're allergic to, and when everything is revving up that immune system, then they have worse symptoms. Next slide, please. So why would people choose cats? If we know that there's a potential for all this, why would people choose cats? Well, again, as you can see, I'm a cat lover. I haven't got a cat at the moment, but I've had cats in the past before. But cats make a wonderful contribution to lives and their physical and mental well-being of people, reducing isolation and loneliness. They can be wonderful. My elderly mother, who's passed away now, but she loved her cat. She used to talk to him. She swore he talked back to her. People do love their animals. Young children, you can see that special bonds with them. So it's a well recognized that they provide a wealth of emotional support and companionship, and they can really increase quality of life in the true sense. So some people choose cats for those reasons and are not expecting cat allergy to follow. So it can become quite a surprise. And because you have this period of sensitization before you have the symptoms, not everyone puts two and two together and connects it. Well, what could be triggering it? What can be driving it? And so sometimes those diagnostic type testings can be quite informative of finding out, well, what can it be? Next slide, please. So diagnosing cat allergy, you will have heard from Tariq, full allergy clinical history is so important. It is the most important thing that you need to do, including family history, so this atopic tendency, presenting symptoms, severity, duration, suspected triggers, what over-the-counter medication they might have tried, how effective it was when the symptoms come on, etc. That's a full allergy clinical history, really, really important. And we have a British Society of Allergy and Clinical Immunology, and they have a primary care group as well, and they're hugely informative and supportive for people who work in primary care. So you can get some really, really good tips from that group as well. They've got a WhatsApp group, and you can always ask to join. So the website for that is www.brsoa.org. www.bsaci.org. So that's something you might like to do, and they will help. If you've got any questions about what actually is a full allergy clinical history and what you need to consider, etc. So specific IgE to cat allergens. Have you heard from Tariq about these tests there, serum tests for specific IgE? So you can do that as a blood test, or if you've got the facilities, and often this is done in secondary care as the diagnostic of choice, is a skin prick test using the cat allergen. But as we know that from what Tariq was saying, a diagnostic test is not 100% accurate. So before getting rid of the cat, if you can have the cat to have a little holiday away from home, and if you don't find any symptomatic relief whatsoever, then is it really the cat that is the culprit that's triggering those symptoms? So it's really, really important before you make any major decisions that will affect the family dynamics in the household, because there might be other members of that house that might love that cat, and you've got all those types of issues as well to deal with. And when I was in clinical practice dealing with cat allergy, the amount of patients would have actually put the husband in the shed or the wife in the shed, etc., rather than the cat is absolutely surprising. So people love their animals, so you do not want to sway them to get rid of a cat, and then that doesn't make any difference to their symptoms. So really and truly, you need to maybe having those types of conversations. And if they can have a period where maybe the cat is looked after by a relative or whatever that hasn't got cat allergy, then you might be able to see. So you've got this history of suspected trigger. You might have a diagnostic test, and then you've got that evidence as well that the symptoms actually get better when the cat's not there, and or the child or the whoever is not in contact with the cat, and the symptoms are much relieved. And then of course when the cat does come back, you've got the symptoms coming back again, and then you've got your evidence there, and then there's big decisions to make there. But I'm going to talk to you about some other ways of managing cat allergy within the home as well. Next slide, please. So we do know that there is absolutely no cure for cat allergy. Avoidance in allergy, in all areas of allergy, avoidance is the best strategy to reduce symptoms, and that's no difference in cat allergy. To avoid the FeLD1, which is the major cat allergen, is is what we really want to try and do. But many clinicians, and I've worked with many, and is common practice is that if you have a positive skin prick test or a positive specific IgE, and there's a suspected trigger of a cat, they say get rid of the cat. And the amount of patients that I've seen in our clinic just crying their eyes out after that advice, it's heartbreaking, because they think that especially elderly people as well, that the cat is their lives, etc. So it's not as simple as that. Many humans and adults, children, many human beings are so emotionally attached to their feline friends. So just to get rid of the cat is very, very difficult. Many of these patients try and reduce their symptoms by medicines management as much as they can, to try and alleviate their symptoms or some risky symptoms, and they might be taking over the years more and more medication to try and reduce that those symptoms. So if they do discover they're allergic to cats, there are options and things that they can try and actively do alongside their medicines management. And we have got fact sheets on the Allergy UK website that will give a lot of information and advice device. Now, all our fact sheets are free to download, and you can download them straight off our website, and you'll see the website at the bottom of this slide is www.allergyuk.org, and so you can there's no copyright on any of the fact sheets, so you can literally just print them off and give them to the patient. So it's quality information that we put together. We have them peer reviewed by expert clinicians, and we have them also lay reviewed for understandability. We used to have the accreditation, information standards accreditation, but that information standards accreditation no longer exists. So we go for best practice, still using that same sort of standard of guidance with all our fact sheets. So you can have confidence that what the information that's in there is as accurate as we can get at the time, and we review them on a regular basis and update them. So things like keeping cat out of the bedroom, washing hands after touching the cat, bathing the cat. A lot of the time this is something that's recommended, and if you know that FeLD1 is on the skin, etc. So you can reduce it by bathing the cat, but it's not for very long. It's not a long-term solution. The cats actually hate that, and so they're not going to like it. So you won't be able to do that on a regular basis, and so that cat allergen will be there. Neutered males produce lower levels than unneutered males, but still it has still significant amounts, enough to cause allergy. High filtration vacuum cleaning. Now, sometimes you've got to make sure that it does what it says on the tin. So how do you know that it cuts cat allergen out of the indoor environment? And so when you've got confidence in product type thing that's been through some rigorous testing, then it's you can sort of say with confidence, yes, that high filtration system does cat allergen out of the environment. Whether it's enough to completely reduce all symptoms, that's another thing, but you can look on our website for all those types of information as well. And also now quite an innovative area, which it was quite groundbreaking and had never been tried before, is a way of actually neutralizing this FeLD1 antibody. And that was hugely significant, because it was thought that if FeLD1 is the major cat allergen, and you can take that out of a way of taking that out of the indoor environment, then surely that must reduce symptoms, but have the cat still live in the house. So there now is new cat food available, which uses egg containing the anti-FeLD1 antibody. So when the cat eats the food containing the egg powder, it binds to the FeLD1 in the cat's saliva and neutralizes it. So it doesn't actually change the levels of FeLD1 that the cat produces, because that's thought to be of some importance, but it just neutralizes it. So when the cat then licks fur, etc., and grooms itself, and that FeLD1 then goes into the indoor environment, over time, if that's neutralized, then that threshold of cat allergen in the indoor environment can be reduced. And is that enough to reduce it below that symptom threshold? So that may be another tool in your toolkit of management things that people can do to actively try and reduce the FeLD1. And what the studies have shown is that it's proven to reduce the allergen on the cat hair by an average of 47%. From the third week of daily feeding. Now, the downside is you have to feed the cat every single day with this, and if you don't, then that FeLD1 might come back, and not all patients would be able to afford things like this. But it's certainly, if you want to think about different ways of managing cat allergen, if the the person says, no, I want to actually live alongside my cat, and it's important for my children, my family, etc., because that human bond is so significant for that family, that is something that they might start thinking, yeah, this is something I might do. So next slide, please. So treatments to manage symptoms. So we talked about sort of management of cat allergy and ways you can actually reduce the allergen in the environment. And then there's the human effect, the effect of the symptoms on the person. So you've heard from Glenys's talk about some of the treatments that are used to treat allergic rhinitis, and you've heard from Anne's talk about that to treat asthma. So you'll know that antihistamines, if you're using them on an ongoing basis, they should be long-acting and non-sedating. There has been research about using sedating antihistamines, and that is not something that we recommend at all. Nasal saline douches, you've heard from Glenys how wonderful they can be. Great advocate of nasal saline douches, and we used to use it all the time in clinical practice, and so many patients used to report great outcomes with nasal saline douches. Very, very simple, but a great way of getting a lot of gunk out of the nose and all the allergen, etc., out those nasal passages. Aqueous nasal steroid sprays, that's something often used in allergy, and we've got ARIA guidelines, which is ARIA, allergic rhinitis and its impact on asthma, and these are all types of things that they all recommend. So combinations we've got of antihistamine and steroid nasal spray, lots of patients find that that's very good as well. Leukotriene receptor antagonists, you heard from Anne's talk about that. Bronchodilators and steroid combination inhalers as well. So all those type of things are often used, and we've that's already been talked about. Next slide, please. So immunotherapy. I can't leave a cat allergy talk without talking about immunotherapy, because this is one of my passions when I was in clinical practice. Why would we ever use immunotherapy? It's costly. It's very, very long in terms of the therapy itself. It's a 3-year course, and you really have to be committed, because the compliance, or the immunotherapy studies are all based on taking it for the prescribed amount of time, etc., all the data outcomes. So compliance is a huge thing that people need to know what they're going into before you embark on immunotherapy. So in terms of cat allergy, why have I mentioned it? Because we've talked about, well, the advice really would be to people were told to get rid of a cat. Now you've seen some of the management of how you can have cats and still not have too many symptoms and try and manage them. If people choose not to get rid of that the cat, you have also those that can live without cats, and so the cat allergy doesn't affect them on a day-to-day life. They've got their bronchodilators and their rescue medication if they come in contact with cats, and it's a short-term thing because they don't own a cat and they don't regularly come into contact with cats. They only come into contact by chance. But just imagine if you've gone into a profession and by chance you're coming into contact with cats regularly, and this is where immunotherapy comes in. And so in my experience, and some of the people that I've done immunotherapy to are vets, district nurses who go into elderly people's houses, etc., and they come into contact with cats, people who are police officers that do raids on people's houses, and they're floored by an asthma attack when they go into somebody's houses. Lots of different scenarios where people will come in contact with cat allergen and have and are at risk of having an asthma attack, and so they cannot do their job because of cat allergy. So immunotherapy retrains the immune system to tolerate more cat protein without them reacting to that cat allergen. So typically patients go to an immunology or an allergy clinic and they will have a complete diagnostic workout run up, and they will then, the allergist or immunologist will diagnose their cat allergy. And then if you know that in that clinical history they tell that how it's affecting them and their profession, etc., and what has been the problem, they might be selected due to the criteria for immunotherapy to cat allergen. So we've got two types that might be considered in the UK. Both of these are unlicensed, but and to my knowledge, there's no licensed cat allergy immunotherapy. So it's usually used off license, and it's in specialist allergy services, and it's very, very carefully regulated and controlled. So the ones that I've come across is the subcutaneous and sublingual immunotherapy. We used to use a lot of subcutaneous immunotherapy in our clinics, and some of them we gave immunotherapy to people with cat allergy for exactly the reasons that I've just said. We're desensitizing vets who are at risk of having to give up their small animal veterinary sort of practices because of cat allergy, and after desensitization they can successfully do their jobs, etc. So they come to the clinic for initial weekly injections, and they have what they call an initial phase, and then they go up to a maintenance phase that usually is about every 6 weeks to maintain that tolerance. So they build that up over usually it's a 3-year course, but some immunotherapies can be used and given a bit longer. And the sublingual immunotherapy, often they're started in the allergy clinic, and then that's something that they do at home. Usually it's like drops underneath the tongue, etc. And some clinics do that, and that might be more also in pediatric clinics as well. For some reasons, they might, be having a cat allergy, not having a cat in the home, but when they're in school, etc., they might be having some asthma symptoms, etc. So the cases are considered by a case-to-case basis based on need, but that therapy can be available for certain individuals in certain circumstances. But as I say, it's not licensed or regulated, but it's highly regulated in those type of services. So if you do ever come across a patient who might be eligible for something like that, or within the clinical history, it's definitely worthy of referral to an allergy service, as is anyone whose triggers give them severe, especially with asthma symptoms, etc., or if their symptoms are uncontrolled in any way, allergic rhinitis symptoms, and they've taken a few over-the-counter medications, etc. You really do need some expert advice and help, and the allergy and immunology clinics that do allergy really are experts in giving that advice and help. Next slide, please. So in 2019, there was a lot of cats that were linked between owner allergies. So we do know that reluctantly people do have to get rid of their pets, and that's something that they will have to be managed very, very sensitively. Thank you very much for listening. I hope you found that will have been of some information use to you. I think we've got a few minutes left for some questions, and then I'll hand back to Margaret, who will do the closing session.
Sorry, I forgot to unmute myself. Thank you very much. So we'll go to the questions. Are there any specific cat breeds that are more likely to cause reactions?
Well, it's all down to this FeLD1. And so FeLD1 is produced by all cats, and it depends on, the FeLD1 in the environment, etc. Are you talking about trying to get a breed of cat that wouldn't give any symptoms to somebody who's got cat allergy? There are no hypoallergenic breeds.
Thank you. And there's another one, you touched on this in your talk. So it says, does the level of allergen in a cat change depending on the gender of the female as in height? So you said that a neutered male has lower levels. What about females on heat, or pregnant females, or nursing females?
Oh, that's a very good question. And I know that the females that they produce similar to neutered males, but I don't know about all the other ones of how much they would produce. But I think it rather depends on the actual person and what their symptomatic threshold is as well.
Okay, now there's a few about kind of whether to have cats or not, or whether to give cats away. And obviously you touched on that quite a lot in your presentation. So there's a question here, would a house cat be more of an issue to an allergic owner than a non-house cat? For example, do outside factors exacerbate the allergens, so the allergens that the cat can bring in, as well as the FeLD1?
Yeah, that's a really interesting one. And we know that pollutants can be problematic with allergens, etc. So maybe we will see that. I don't know of any studies specifically to answer that question directly, but I do know that some people who have cats in the house, they have never really been tested previously to think about the cat being a trigger, or they know that they've had a skin prick test, or they've had a blood test and it's come up positive, but they still choose to have the cat in the house, and they live with their symptoms. And we used to find that in clinical practice all the time. And over time, sometimes they don't realize that the cat is even causing any symptoms until they go away. And they might go away to one very common scenario we used to come across is when young people go off to university and suddenly their symptoms get a lot better, and they're not in contact with cats, etc. Their symptoms get a lot better. They reduce or stop their inhalers, etc. And then they go home for the holidays, and then they come in contact with that cat, and then they have an acute asthma attack. And so that was quite a common scenario that we came across. And so that's really important to note, that some people can have that period away with not having too many problems, and it's when they come in contact with a cat that can be very, very problematic. And that's what we used to find with people like police. They might know they're allergic to cats, keep away from cats at all costs, etc. But they do a raid, and this little tiny cat floors them completely, and they have to go out because they feel such a tight chest, and their bronchospasm just means they have to sort of get out that environment, so they can't do the job that they're expected to do.
Thank you. So this is kind of continuing on with that kind of theme, because there's a question here, what would you advise if a family has a cat and the child is allergic to the cat? And also, what advice would you give for visiting friends and family with cats if you know you're allergic to cats and you don't have cats in the house? And there's a third part to this as well, as you talked about there having the break. How long should you have a break?
Yeah.
If you're concerned that it's a cat allergy,
Yeah.
how long should the break be?
Yeah.
To understand. And should your break be from the house rather than the cat being removed from the house? It's kind of a three-part question.
Yeah, and they're all really great questions to ask yourself, because and how long do you leave it before then the cat comes back in? So, if you're going to have like any test period or something, you've got to leave it at least 5-6 weeks minimum before and try and remove all the FeLD1, etc., before you can start seeing any symptom reduction, etc., because it's so sticky. So none of that really is completely evidence-based, because you've got to play it case by case. And I think this is where it becomes such a grey area, is because a lot of clinicians will just say, get rid of the cat, because it takes away all that. And in time, not having the cat in the house will reduce those symptoms over time, especially if you then clean the house, and do all the things from a management point of view. But then you've got the emotional side, the emotional attachment that the family feels to the cat. And so many people actually don't always listen to that advice, and they choose to try and go down the route of the cat not being in the bedroom or not sitting on the person's knee, etc., but the cat's still around, etc. And that's why I try to give more of a broader type of management of how somebody might try and manage that alongside symptoms. And when their symptoms start reducing or they come under control, etc., then it's important to have those conversations about when it's time to reduce types of medication, when it's safe to do all that type of thing. And so with what I was saying about this new type of way of managing, that's actually had some research evidence behind it, of being 47% reducing the FeLD1 after 3 weeks from feeding the animal point of view, then that's quite significant. And that's something some people, some households might like to consider, but it might not be for everybody. And cost might be a barrier to that for some people. So I don't think one size fits all. It's a very difficult question to actually answer directly with any evidence base to how long does a cat need to be outside the home before you don't get any of the FeLD1 anywhere in the house. I know from some of the studies that I've read that they still detected FeLD1 in people's houses 2 years after the cat had vacated. And obviously, if you're going to just do a trial period, that's a long period of time for any family to say, okay, give away the cat, to your relative or whoever it might be. And when does the cat come back into the house, or do the children that are not allergic to the cat go round to see the cat, etc.? And then they might be bringing the dander back into the home again, etc. So cat allergy is one of those things that is really, really quite an emotive subject, and especially for those who've got cats. And when people relinquish them, that sometimes can have knock-on emotional effects as well.
Thank you very much, Amina. That was a fantastic presentation and very interesting and informative about cat allergy. I'll just take you to the close. I'd like to thank all our speakers today for kind of very, very interesting presentations. Generated a lot of interest and a lot of questions, which has been fantastic. And thank you for all their expertise and patience in answering all the questions. I'd like to say thank you to Glenys Scadding, Tarika and Shannon Away, Anne McMurray and Amina Warner for all very interesting presentations. I hope you found this webinar very interesting, and I may be interested in our upcoming webinars we have planned over 2021. On the 1st of September, we've got Managing the Needs of Allergic Patients, a Pharmacist's Role. 14th of October, Food Allergy in the Spotlight. 9th of November, a focus on chronic spontaneous urticaria. And the 1st of December, allergic skin disease, atopic dermatitis, and chronic spontaneous urticaria. And registration is now open, so you can register for any of these webinars and go to www.allergyuk.org/masterclass. Thank you very much, and I hope you've all enjoyed the webinar today.